Morning, everyone, and welcome to MHA's Joint Commission Update. I'm Kim Stevenson, Director of Workforce and Clinical Affairs at the Massachusetts Health and Hospital Association. Thank you all for being here today. A few logistics before we start. We are in listen-only mode today, so if you have questions, please put them in the chat feature. The questions will come directly to us, and we will do our best to address as many as we can during the virtual event today. I also want to take a moment now to thank MHA's 2025 annual sponsors and strategic partners for their support in underwriting today's webinar, which is just one of many events we have throughout the year to connect our members with leading experts to help address timely issues like the one today. Today, we have the opportunity to hear from leaders from the Joint Commission on updates and accomplishments and improvements to the surveys. Next, we will hear from a hospital's inspiring journey to achieve the Joint Commission Health Equity Certification. And finally, we'll conclude with learning about recent survey experiences from 3 Massachusetts hospitals that will help to inform others expecting surveys this year. For this first session, we will hold questions until after all 3 Joint Commission speakers have finished, but please do add them to the chat during the presentation and we will review them at the end. Without further ado, I'd like to welcome our morning keynote speakers from the Joint Commission, Dr. Elizabeth Mort, Vice President and Chief Medical Officer, Robert Campbell, Senior Director, Standards Interpretation, Accreditation Decision Management, and Medication Safety, and Mark Crafton, Executive Director, Strategic Alliances. Thank you all for being here today, and I will now hand it over to Dr. Mort to get us started.
Well, good morning, everybody. It's just great to be here. I'm going to share my screen. Just give me a second to get that going. All right. Can I get some confirmation that the screen is visible to the audience?
Yes, you're all set.
Perfect. Well, before I get started to share, and what I would like to do today is kick off this presentation by the 3 of us with some updates about the Joint Commission. But before I do that, I just want to say how excited I am to be here. My name is Liz Mort, and I am the new Chief Medical Officer at the Joint Commission. I've been there 10 months, but I spent a lot more time in the state. And for those of you in the audience, I hopefully have met some of you in the past, but I've spent a long time working at Mass General and MGB and some of the community hospitals in the state on healthcare quality. So as I present today on the Joint Commission, it's really with great pride to now be part of this team. And I left Mass General in 2023, and I was looking for an organization for my next chapter where I could use my expertise and my experience at a larger scale. What I must say is that when people ask me, has your experience met your expectations? I say no. My experience has exceeded my expectations. And the Joint Commission really is a wonderful organization. When I was a CQO at Mass General Hospital, I believed in the Joint Commission. I was excited when the Joint Commission would come to survey our institutions. We organized our performance improvement on the chassis of accreditation, and we knew that program that was coming through called the survey was one that was going to hold us accountable, but also inspire us to do better. So it's been a great experience for the last 10 months and a great pleasure to be here today to share some of the highlights of the Joint Commission. So one of the things that you may not appreciate is that the Joint Commission is really embedded in large organizations in the United States and has been since we started in 1951. When I say embedded, that's not quite the right word. I would say working with. We are not embedded. We were formed with these 5 organizations: American College of Surgeons, American College of Physicians, American Medical Association, American Dental Association, and American Hospital Association. You know these organizations. They're all committed to ensuring that quality of care is as good as it can be for all patients. And so the Joint Commission was formed, the Joint Commission, based on that. So we are very, very well aware of what's going on in these different organizations, and there's a really nice blending of spirit and forming our goals and our programs together. Our mission was revisited recently, and I'm just going to read it to you: enabling and affirming the highest standards of patient safety and healthcare quality for all. Affirming is the part that our surveyors do when they come to your organizations. They're looking to see whether or not you are compliant with our standards. But they're also, as I'm sure you can all attest to, our surveyors are increasingly over the last period of time, and more so in the future. They're going to be working to help inspire you not only to be compliant with standards, but to be reaching a level above. How can they help you as organizational leaders get that spirit of not just being compliant, but also reaching for the next goal? That's what we're all about. And you're going to hear more about that from my colleagues. Our vision is really important, and I'm just going to read it. Our vision is that all people always experience the safest, highest quality, best value healthcare across all settings. That's really what we're here to do. And I know that that resonates with you all in Massachusetts, because it's really about making sure everybody, all patients, no matter what population of patients you might be talking about, the elderly, the rural, patients who are in socioeconomically disadvantaged groups, by gender, et cetera, all patients get a shot at getting the best care possible. That's what we're committed to do. The Joint Commission has a new leader. Dr. Jonathan Perlin is our leader. He started in 2022, so he's in his third year. And again, when I left Mass General Hospital in 2023, I started talking to people about my next chapter. I wanted to use my experience and expertise at a bigger table, a platform organization, so that I could see change at scale. Dr. Perlin has done many things in his career. I've watched his career, and he is a leader who makes legendary changes. He had a senior role at the VA, he had a senior role at HCA, and when he left, those organizations were different for the better. And I have full confidence that he will do the same thing at the Joint Commission. He is doing the same thing. And, this quote, he views it's our responsibility to drive value, to be agile, to reduce burden, and inspire innovations with the organization we serve. And that's exactly what we need. The Joint Commission is well established nationally and internationally. I'll tell you a little bit about that as well. But we're taking it to the next level, and we're doing these things that Dr. Perlin has identified as his goals. He's hired a new team. Not everybody at the Joint Commission is new. Many people at the central office, where I now go several times a month, have been there for a long time and really understand the history, understand the processes. But Dr. Perlin has hired a lot of new people. And he's hired people who've worked in organizations like the ones you work in and understand what it's like to try to advance quality and safety with all the headwinds that we have currently. And if we always have headwinds, I would say the headwinds right now are particularly challenging. But the folks on this org chart are people who've been there. And I believe that's one of the reasons why he invited me to come work with him and this wonderful team, because I've been there. I get it. I understand what it's like to have a busy emergency department. I understand what it's like to have to do drop and run change in your operational models under COVID, or the Boston Marathon bombing, or other events that we've all lived through together. And many of these leaders would have their whole portfolio of stories as well. So this team is really just brand new. And many of the folks that have been at the Joint Commission a long time are very involved in helping us understand the history, but really importantly, they're helping us design the future. So what you're going to be looking forward to seeing, and what you are seeing, is sort of on this slide. I'll just give you a couple of words on each. We are the global leader in accreditation, not nationally only. We also are that globally. And we are looking at quality across the continuum of care. We have programs, and not just for hospitals. I'm sure some of you are here not to learn about hospitals, but other parts of the care continuum. We have accreditation programs across that continuum. I'll tell you more about our help agenda in a minute, but basically the help agenda is what John Perlin set up in the first couple of years, which basically establishes the fact that healthcare is not just about what happens when you get to a primary care office, emergency department, what happens in home care or in a hospital. Healthcare is what happens in your community. So our help agenda establishes a broader platform to inspire institutions to provide roadmaps so that we can address those very, very important health challenges as well. Over time, and some of you may be experiencing this, all of you will have opportunities to experience it in the future, is that we're trying to tailor our approach more to you, what your needs are. At this point in time, nationally, about 80% of hospitals are in systems, right? And physicians, about 70% of physicians are employed. Very different than it was even 10 years ago. So organizations have different needs, and we are listening and we are flexing to meet the needs of the organizations we serve. We set the highest bar for patient safety. National patient safety goals, you all know those, you probably could recite those by heart. Those are actually considered above and beyond what the conditions of participation require, by and large, by and large. I'll get into that a little bit in a minute. We're focusing more on continuous improvement. We come in every 3 years for hospital survey. We've heard from the hospitals that we serve is that maybe some touch points along the way, just to help us track, would be helpful. So more about that from Robert. And then mission aligned partnerships. I told you I was looking for an organization that was a platform organization, a big table, lots of people sitting around that table, thinking about how together we can be more than we can be independently. And Dr. Perlin with the team that I just showed you on the org chart is developing some really exciting mission aligned partnerships. HELP agenda. So HELP is an acronym that stands for health equity, environmental sustainability, learning and performance, integration and improvement. Just a word on each. Many of you probably have had the opportunity to hear John Perlin speak about this. If you haven't and you get the opportunity to hear him, I would strongly encourage you to do so. So I read to you our vision statement, which is all patients always receive, et cetera. That's really talking about health equity. Not all patients come from the same place. Not all patients need the same roadmap. And we're encouraging organizations to think about the populations they serve, stratify data, and come up with solutions that meet the population that they're interested in addressing with their interventions that meet that population where they are and give them what they need. Environmental sustainability. Again, we have a new certification, a voluntary certification. We have about 120, I believe, institutions nationally who have signed up or have been certified. And it's basically, again, about encouraging healthcare organizations to begin to be more organized and disciplined in their commitment to reducing waste. It needs to happen. Your employees want it to happen, and we have a roadmap to help you on that journey. Learning is a broad goal. The learning health system approach, many of you are familiar with it. We don't have time to get into the details, but it's basically about how do you organize your institution, your system, no matter what you do, and think about how to continuously learn and take that learning, share it, and through that learning, advance your performance. And then performance integration and improvement is a fast follow to that. How do we help organizations not just affirm that they're doing well, but to inspire them to do better? And we're working on some new reports. You'll see that from Robert. We're working on some new surveys. You'll hear about that from Robert, and some new programs to do that. We have an event coming in September. Stay tuned. You'll hear more about it, which will be our first ever event to really advance our performance improvement agenda. So approach tailored to organizational needs. Our survey, this is a slide. Robert will get into more detail, but you're all familiar with the SAFER matrix on the left. You're all familiar, having been in a room where you get the SAFER matrix with all the EPs and the standard codes. Now they're going to have the decoder ring, and you'll hear more about that from Robert, which will make it a lot easier for you as leaders to communicate this information within your organization, to your leadership, to your boards. Ditto on the benchmarking. The reports will include benchmarking, how you as an organization are doing relative to others. That will be helpful to you to guide where you're going to put your improvement energy, and to give your leadership and your board an opportunity to see how you're doing relative to other organizations. So these are coming attractions. You'll hear more from Robert, but very, very exciting. It will make the survey higher value, and people are really, really excited. Those of you who have heard about it are really, really excited. Everybody's really, really excited about that. Continuous engagement is still evolving, but the idea is to not just pop in every 3 years, but to have continuous touch points that allow the organization to communicate in continuously to ensure that the programs that you're advancing are on track. So more to come on that, but that's one of the first waves of advancements is coming out of the work that John Perlin set in place. Now, I mentioned that national patient safety goals honestly are above and beyond what CMS conditions of participation require. That was a little bit lost on me in my previous roles. But when you look at the details, which I've had an opportunity to do now for 10 months, the national patient safety goals, things that are listed on the left side of this slide, critical results, culture of safety, equity, imaging safety, et cetera. Those are really important to delivering safe patient care. We can all agree on that. And the Joint Commission focuses on those and makes sure that we have standards to help you integrate what you're trying to do into your entire accreditation program. To me, as a manager, as a leader, having that integration of performance improvement based on the Joint Commission COPs, what we have that are above and beyond, are all the things that we want to do anyway. So you're organized on a chassis that's broad and solid and is focused on the right things. A word on our certifications. Mark will tell you a little bit more about these. We have certifications across the full continuum. I won't get into the details here, and these are voluntary. Many of you probably are involved in some of them. You're all working on the healthcare equity certification. But having lived this in an academic medical center and experienced this at a large system, including community hospitals, these programs give leadership a sense of direction. You're collecting data, you're adhering to standards, you're part of a collaborative in many of these. And in addition to the accreditation programs, these certification programs, again, it rounds out, it integrates these certifications into the performance improvement plan you'd like to do anyway. So, I'm very, very committed to making sure that leaders have the programs that they need to stay as efficient as possible. Global leaders, we are in 75 countries. I've learned a lot more about this in my last 10 months. It's really quite amazing to see the energy of the Joint Commission international teams, hearing about their conferences, hearing from the hospitals that they accredit. And we are increasingly trying to make sure that everything we do is sort of cross-enterprise. So more detail than we have time for today, but happy to take questions on that or speak to you afterward if you're interested. I had the opportunity to meet our surveyors in January. We had a big meeting in Chicago, and these professionals are very, very committed to making sure when they come to your organizations, you're getting the very best experience possible. An incredibly committed, energetic, passionate group of learners who are very excited about some of the changes that we're planning. National Quality Forum and the Joint Commission came together a couple of years ago in a strategic alliance, and we're benefiting tremendously from the measurement expertise that the NQF has, and in addition, NQF is very involved with payers. Dana Gelb-Safran is the CEO, and she's on the team, obviously. And you'll remember, this audience will remember the alternative quality contract, the Blue Cross Blue Shield of Massachusetts. And that sort of strategy, that thinking, how can we use these certifications? How can we use these measures and partner with payers to develop win-win solutions? So that's just a down payment, but more to come on that. And it's great to have the NQF team and the Joint Commission team working so closely together. Another strategic alliance that just was announced a few months ago was with the National Association of Healthcare Quality. Many of you know of them and probably are certified by them. They basically are focused on workforce competency. And I'm sure you'll all have experienced having been given a role yourselves or hired someone into a role where you wish, gosh, I wish I had a full set of competencies so I could really, really be good at this. And NAEQ has a wonderful framework on what competency is all about. They have certifications to help you or your team gain those competencies. And they also have programs for institutions to think about not just a one-off, but how do you sort of organize your competencies, particularly useful for systems where you may have 3 or 4 people in 3 or 4 organizations that are part of your system, and you want to make sure they all have the competencies that they need to get the job done. So it's very exciting to be working with NAEQ as well. So that is just an overview of where the Joint Commission is in 2025. We've been here for 51 years, and each CEO does something a little different. The current CEO is really extraordinarily motivated to make the Joint Commission, how shall I put it, to make the Joint Commission the organization that it really has the promise to be. There is no larger organization with this role. There is no other organization, I would say, that is there as well connected and understands what our professional societies are trying to do to get care to the level it is, to make these kind of strategic alliances with experts in NQF and NAQ, and to work with all of you on the really stunning work you've done in health equity. Congratulations. I'm very proud to be from Massachusetts. And I'll stop there and just say thank you very much for inviting us today. And I'll take down my slides. And you'll be hearing now from folks who are really going to be tailoring their comments to what you need to know specifically about the surveys and the certifications that you're involved with. So I will pass the podium to Robert Campbell.
Thank you, Dr. Mort, and good morning, everyone. Again, thank you for taking the time to join us today. So I'm going to be going over two sets of topics. The first one will be around the survey experience enhancements, and then after that, I will be going into some specific scoring data for the state of Massachusetts and some comparison data so you can see how the surveys that were conducted in 2024 aligned up against national themes as well. So starting off first, just a quick reminder to everyone, it is important to the Joint Commission that we are there to provide you a thorough and credible evaluation of any risk points that you have. So the mantra that we have continued to utilize within the Joint Commission is that we want to make sure at the end of the survey that you have an accurate report and that the findings are correct. Not that the Joint Commission was correct or the organization was correct, but instead there's a mutual understanding of the risk identified, and that's what's reflected in your final report whenever it's published to your extranet site. So just as a reminder, each and every day of your surveys, there is an opportunity for a special issue resolution session. If during that time you cannot come to agreement on an issue, there is always the opportunity for a collaborative call to occur. All you have to do is ask the team leader of your survey team or the surveyor if they're there by themselves if they can have a collaborative call with you in the central office. The surveyor will then notify my team, we'll get on a call, and we'll work through the process with the organization and the survey team to understand where the perception of risk occurs and then help to make a final decision as to whether or not that item should be reflected in the survey report. Those are not punitive. Surveyors are happy for them because it allows a third party to get in to help engage in the final resolution of the issue and continue on conducting survey activity. So I did see where someone had commented they recently experienced our new survey report. We're very excited about this report. For as long as the survey report has been in existence, it's always been alphabetically. So for the most part, most survey reports start with environment of care findings because that's typically the first chapter reflected in survey reports. Now, we know that 60 to 65% of survey reports or more are from the physical environment. So it's very possible that you could have a 50-page report and the first 20 to 25 pages be physical environment. And then buried down in the report is a high-risk finding related to something to do with infection control or patient care or patient rights. So we also noticed that organizations were being challenged with understanding what would be looked at in a Medicare deficiency follow-up survey. So as a result of the feedback that we received from the organizations that we serve and in working with them, we redesigned the report that went live last month that changes how the report is displayed, and it has several new enhancements. The first one is that on your SAFER matrix, next to each standard and element of performance will be listed a short name, which is an abbreviated definition or description of what the element of performance that is required. Now, we were limited to 30 characters, but we have worked hard to make sure that it's easy to understand. And for those of us that live in the accreditation world every day, it's easy for us to understand that IC 60101 EP3 is talking about reduction of healthcare acquired infections, or that PC 10203 is talking about assessments, and EP4 is talking about histories and physicals. But for the executive teams at the organization and the frontline staff and middle management who may be involved in reviewing these survey reports and in creating action steps and action items, it's not as familiar to them. So next to each standard and element of performance and in the accreditation survey reports today, there is that short name. And as we work through this slide deck, you're going to see where I've listed certain Joint Commission requirements, and I've listed that short name next to them just to get some familiarity with that. We're in the process of finalizing. In fact, we met yesterday and completed the short names for all of our certification, validation, and verification programs, and those will be in a release here in the very near future through our database system. In addition to that, instead of us listing findings in the survey report by alphabetical order in the chapter, we've now modified the report to list the findings based on what box they are in on the SAFER matrix. So your report will start with those issues that are the highest risk and most widespread, and it will end with those observations that are lowest risk and limited in scope. In addition to that, we also changed the CMS conditions of participation summary page so it's easier to read and understand. The process that did exist was somewhat challenging to understand, even for those that worked in this space every single day. We've also removed some of the repetitive information that was in the survey report. At the end of most reports, the last third of the report was typically a summary of all the Joint Commission requirements that were scored and the CMS conditions of participation. What we found was that that was unnecessary information because it was already embedded within the report. In addition to that, for organizations that printed these reports, it added quite a bit of unnecessary paper. And as we're looking at our ways to support sustainability, that was one of the decisions that was made. Instead, what we've done now is we've aligned the condition of participation that has been crosswalked to the Joint Commission standard at each finding. So you now have a representation of the Joint Commission requirement, the observation, and if there is an attached federal requirement, you can see that as well. And then lastly, something that's been asked for a number of years. I've been the Joint Commission for 12 years now. I functioned as a surveyor full-time my first 6 years at the Joint Commission. One of the things that we always had to remind organizations is to make sure that you captured a copy of your preliminary report at the end of the survey, because the report would come down at midnight. We've now changed that coding, and that preliminary report now remains available on your extranet site until your final report has posted, so that you don't have to worry about trying to capture it before it comes down. Here's the example of the new CMS condition of participation summary page. You will notice now that you will have the level of deficiency only at the parent tag. In the previous report at 4223B, just do this real quickly here. In the previous report, this may have said standard and this may have said standard, but because of the combination of findings under that condition of participation, it may have rolled up to a condition level. This created quite a bit of confusion, especially whenever it became time for the Medicare deficiency follow-up survey. So we have removed the child tag scoring, and we now only list that scoring at the parent tag. So you can see here that 4223 is condition, 482.12 is condition, and 42.42. The other thing that we did in the survey report is that we also put all condition levels at the beginning of the summary. So you'll see all condition level deficiencies at the beginning of the summary, and then the standard level deficiencies will follow. Here's an example of the new report. So as you can see here, you have the SAFER placement. You do have the standard element of performance, the Joint Commission requirement, the observation, and then the crosswalked condition of participation text. This column used to have the level of deficiency, but many times it was not accurate because that was the level of deficiency for that one single observation. And as you all know, the level of deficiency is determined at the conclusion of the survey when all of the risks have been aggregated together and the manner and degree can be determined. Again, you will see here that moderate pattern is the highest risk in this report, followed by low widespread, low pattern, and low limited. So again, as we move from box 10 down to box 1, this goes through. Some final report changes. So you now have an executive summary that will come out in your final report. And in this report, you can see here the short names that exist that are attached to these standards and elements of performance. In addition to that, you now have a checkbox and a column for each follow-up survey activity that will occur so that you can know exactly what standards and what observations will be listed during that follow-up survey activity. We've also now included sections within the report, the final report. So in this particular case, this organization had an immediate threat to health or safety, which also generated condition level deficiencies. So there's now a section of the report called Immediate Threat to Health or Safety Abatement Survey. So when the organization receives the final report, these are the actual observations that will be reviewed during that on-site activity. In addition to that, in the Medicare Deficiency Survey, it will list everything that will be looked at during that Medicare Deficiency Survey that had a parent tag at a condition level deficiency. Now, that does mean there could be repetition of findings, but we wanted to make sure the organization was clear in understanding exactly what would be evaluated and reviewed in each follow-up activity that's conducted on site. We also have launched, in addition to that, we have launched the document upload. So this is another request that came from the organizations that we serve. And as many of you know, we have several appendices in our survey activity guide of required documents that are requested at the beginning of the survey. And then throughout the survey, there are many documents that are requested, sometimes in duplication by 3 or 4 different members of the team. A couple of things that this creates for the organization is, number one, undue burden to print the same policy 3 or 4 times. In addition to that, when we think about environmental sustainability, we're also asking you to print a document 3 or 4 times as well, which is unnecessary. So now there's an option whenever a hospital has a full accreditation survey, the organization can upload their documents to a SharePoint. The documents cannot be uploaded until the first day of survey. And then at the conclusion of survey, that file is eliminated and the Joint Commission no longer has access to it. What this does do, though, is allow you to upload those documents there into one repository so that if more than one surveyor needs to look at that document, they can access it from that secured SharePoint site. In addition to that, it avoids the need to have the mountains of three-ring binders, et cetera, that exist today as you're preparing for your accreditation survey. Again, this is where you can find that. If you have questions at the beginning of your survey, you can always reach out to your account executive who will be happy to assist you and walk through the process, as well as the survey team as well. There's also a new product that we listed for the Safer Peer benchmarking. So we've been asked a number of times by healthcare systems, but I can also tell you as a surveyor when I was in the field, it was very common for organizations to ask on the last day, so how did we do? How do we compare to everyone else? We now have technology that allows us to tell you that, and that is made available to you after your final report has posted. It takes a day or two for the system to upload the final data once your final report is posted. And again, remember, if you do submit any clarification information, we have to wait for that to be evaluated as well, so that you have the most accurate information at that time. A couple of things to keep in mind around the safer benchmarking peer group. Had a hard time talking this morning. It's going to focus on the most recent full survey. So if your most recent full survey occurred in 2023, then that's the data that you will see for your particular organization. The matrix that's utilized to determine how we compare yourselves to others is based on the number of requirements for improvement in your report, what chapters were scored, and where were they placed on the SAFER matrix. Now, one of the nice things about this tool is it's able to normalize hospital surveys. So for example, if you have a 500-bed hospital, and then you have a 150-bed hospital, clearly the 500-bed hospital is going to have more observations simply because it's a larger survey team. There's more eyes to look at particular issues, more charts are going to be reviewed. And based on that, that would be a larger report. So what we've been able to do is normalize it through an algorithm that we utilize that looks at the number of surveyor days, and it takes that into account to normalize the value so that you can compare the 500-bed hospital to the 150-bed hospital, and in doing so, get a consistent value to compare those. Now, when I show you the tool, we do break it down by hospital bed size so that you can find hospitals within a certain bandwidth of beds. And that was the model that we used to get a more precise number at the end. Also, this only compares to the like hospital of how the organization identified themselves in their electronic application. So we have found some errors that exist in how hospitals have identified themselves. And when that happens, that does, you will notice that whenever you pull up the SAFER benchmarking tool. And again, reach out to your account executive, let them know if you find that it doesn't appear that the peer group assigned to your organization matches how your organization identifies itself. We are working through the other accreditation programs at this time, and hopefully throughout the year, you will see us publishing those in additional accreditation programs. So here's an example of the tool. If you have not had a chance to look at it, you would find this tool on your Joint Commission Connect extranet site, where you found the SAFER tool. You will now find the benchmarking tool right below that on that separate hyperlink. What you see on the screen here is when you first sign in, you will sign in with either with the HCO ID number or with the email address. This initially was only granted to the primary accreditation contact for security access, but in the same way that you can grant access to others within your organization, you can do the same with this tool as well. So in this particular example, this organization signed in. Their last survey was in 2023. They had 23 requirements for improvement, and their percentile rank overall was 53%. What that means is that they performed better than 53% of acute care hospitals that are urban, general, and 100 to 299 beds. In addition to that, they had 858 organizations in their peer group who said they were general acute care hospitals that were between 100 to 299 beds and in an urban area. When it comes to determining urban versus rural, what we have done is tapped into the Census Bureau, and the address of the primary location on the application is what is utilized to determine urban versus rural based on census guidelines. So this is the beginning screen. So what this is telling you is that this organization is in the 53rd percentile. But if you want to capture a little more information and understand what drove that, you can then go to domain performance. And you'll see that here that we have several domains. So again, this is their overall findings. For national patient safety goals, they were in the 100th percentile, which means no one performed better than they did. For infection control, they were in the 59th percentile. Leadership 100th percentile, medication management 12th percentile, physical environment 53rd percentile. Now you can take this a step further. You can then go into each domain. So for example, in this particular domain, they can actually pull, so this is for the physical environment. And what this shows is that they had 4 findings and the average was 10.6. When they click into this particular domain, they can see the actual observations that are within that domain and compare to the top scored standards with that peer group in the same domain. You are then able to, if you want, under the observation text, to click on these 3 little dots here, and then you can export this data into Excel if you wish to use it for other purposes as well. So again, you can dig down all the way to see how you ended up where you are. And again, noticing here that in this particular example, there are 858 organizations. This is how they identify. The focus area here were those above and beyonds that Dr. Mort mentioned earlier. And then you can compare what your average are, what your RFIs were with the average of your peers, what you had scored, and what your peers had scored as well. So I kind of want to change gears now and talk a little bit about the accreditation scoring data for 2024 in the hospital accreditation program. So what you're going to see here, and I apologize, I'm trying to make this little bar go away. What you're going to see here is for 2024, the Joint Commission conducted 1,158 surveys in the hospital accreditation program that generated 17,162 requirements for improvement. In the graph of the table that you see here, you will see those standards and elements of performance that were scored in the top 10 for the clinical chapters. So to align you to this, in essence, 56% of all surveys conducted in the hospital program, 56% of those hospitals had MM 060101 EP3 scored. And as you can see, the short name attached for that is medication administration per order. When we compare that to the 32 hospitals surveyed in the Massachusetts state during 2024, Massachusetts performed better. Only 36% of those organizations had MM 060101 EP3 scored in the same time frame. So as you can see here, in the clinical chapters, the state of Massachusetts performed better in 8 of the top 10 clinical findings or standards and elements of performance for 2024. However, when we look at the environment of care and life safety code, what we also call the physical environment, you see in this particular case, the state of Massachusetts only performed better in 3 of those 10 areas. So in the other 7 areas, the state of Massachusetts had a higher percentage of organizations that were scored, respectively, compared to the national comparison group for those top 10 physical environment standards and elements of performance. When we then look at 2024 Massachusetts, this was the top 10 for Massachusetts that were scored. You can then compare that to the national as well. This is for the clinical chapters. And then again, when we look at the physical environment, these are the top 10 standards and elements of performance that were scored in the state of Massachusetts in 2024 based on those 32 surveys. And again, you can see how Massachusetts compared to the national numbers as well. So what I want to do now is I took the top 5 standards and elements of performance. I want to walk through what the common trends were there, and this is specifically for the state of Massachusetts. One of the things that you heard Dr. Mort talking about earlier was how the Joint Commission is continuing to learn and advance technology that we use. So what you're going to see here is a AI summary that I pumped into the AI, which is on a secured network inside the Joint Commission platform, all the observations for the state of Massachusetts. And I asked it to provide for me the top 3 themes for each of these standards and elements of performance. So the goal today is really to give you those themes and give you ideas of what we're seeing consistently for the top 3 themes. I am interested at the end of this, if people want to put in the chat, if this type of summary is helpful for you. We're trying to use this instead of going through several thousand lines of data where we may miss particular themes. But I would like to know if this model does help. So the top 3 things that we have are improper sterilization and storage of instruments, non-compliance with cleaning disinfection protocols, and inappropriate staff practices and attire. So as many of you are aware, in the middle of last year, we did convert our infection control chapter, and in doing so, infection control standard IC 060101 EP3 became much broader because it was put in place to actually address the reduction of all healthcare acquired infections, not those just related to sterilization or high level disinfection. So when we look at the first theme here, what we noticed were that instruments were not sterilized properly, stored properly, or were expired. What we're finding here is where organizations are not doing particular steps as required by the manufacturer's instructions for use. Now, unfortunately, this is an area that can go real quickly from an observation in your report with a condition level deficiency to something much greater like an immediate threat to health or safety. So it's important to understand if the instructions for use require that you use certain types of cleaning products, pre-cleaning products, etc., that those products are properly used and vetted. And anytime you go outside of the manufacturer's instructions for use of a particular surgical instrument, you need to have documented evidence from the manufacturer that ensures that the equipment is properly cleaned and sterilized and ready for patient use. That really covers those top two ones. The last one that we see here has to do with proper PPE in the OR areas. Hand hygiene has popped back up quite a bit as not being done according to the CDC or WHO guidelines and in accordance with organization policy. And then lastly, transporting of soil or biohazardous materials, specifically around those instruments after a surgical procedure, not being properly contained based on OSHA requirements and organization policy. Under PC 020203 EP11, which has to do with food being stored properly, the three areas here were non-compliance with temperature monitoring, poor hygiene and cleaning practices, and improper food labeling and storage. Again, you can see here where these challenges exist based on the sub areas and evidence that's provided within each bullet point. Under MM 060101 EP3, medication administration per the order, there were three particular areas. The first one had to do with titrations. I would tell you, I'm in the process now of doing a deeper dive into the national data here. The most common issue that we see for titrations is that initial starting dose and it not matching the order. And what we're finding is this area where the pharmacy staff are recommending a certain starting dose that's listed in the package insert, which does not meet the needs of many of the patients. So I really encourage you to look. We do not hold you to the package insert for dosing of medications. That's a clinical decision. And so it's important that pharmacy works closely with nursing and medical staff leadership to agree on the most appropriate doses in those orders, which by in turn should reduce the number of findings that we're seeing in this area. Under symptom management, you pick the symptom, and what we're stating here is that there are multiple orders used to treat certain symptoms based on the significance of those symptoms and in the assessment, and then making sure that the proper medication is given based on that assessed symptom severity. And then lastly, documentation and order clarification. In this particular case, there were unclear orders on when to give which medication, and that was found. And then there was not a consistent approach to administering those medications throughout the medical record. Under National Patient Safety Goal 150101 EP5, suicide risk policy, the three themes that we're seeing here were lack of training and competency assessment, failure to follow policies and procedures, and inadequate policies and procedures. I think it's really important to look at this inadequate piece because there appeared to be systematic issues with the policies and procedures that either did not exist at all or they did not match what the documentation was in the electronic medical record. So it's really important to make sure that as you're developing policies and procedures or as you're developing documentation components within your medical record, there's alignment in what your policy requires and what your medical record requires for documentation. Under PC 020111 EP2, resuscitation equipment and supplies are available. These three areas have to do with inadequate or inaccurate logging. So majority of the time, it's missing defibrillator checks or the checks were not done in accordance with the manufacturer's package insert or instructions for use. And then lastly, expired or improperly stored equipment. Moving on now to the physical environment, ECO 20601 EP1, interior spaces are safe and suitable. The most common things that we see here are stained or damaged infrastructure, inadequate maintenance, or safety concerns. I want to pause here for a minute and talk about stained ceiling tiles. I think that we all know that stained ceiling tiles are something that make us all kind of roll our eyes when it's scored. But there's a larger issue that needs to be addressed related to the process of dealing with stained ceiling tiles. If there is a leak that's occurring that's causing these ceiling tiles to be stained, The stained ceiling tile is a symptom of a larger problem. And if we think about our facility being our largest patient, in the same way, if a patient has a fever, then that's a symptom of a larger issue. It could be an infection, it could be a number of other things. So, same concept here. A stained ceiling tile is a symptom. And what we really need to do is transition the concept of changing the tile to really investigating, why is the ceiling tile stained? Is there potential mold? Is there a leak in the ceiling? Is there a leak in piping? Are there things that need to be addressed that are causing the symptom? And many times what we find is organizations are surveyed and scored time over time for stained ceiling tiles without addressing the actual cause of the ceiling tiles to be stained. EC 020501 EP9, utility system control labels. What we see here is mislabeling or lack of labeling of breaker panels. We find that particular spare breakers or empty breakers that aren't identified are left in the on position, or there's inaccurate labeling for the legends of the panels. LS 020135 EP4 has to do with dedicated sprinkler piping. Frankly, there was only one theme here, and that was that the sprinkler piping was being used for other purposes other than just delivering the water. There were wires draping on them. There were ceilings attached to them and being held by the piping, etc. So making sure that those sprinkler pipes are free and clear of any obstruction, and they must be individualized and contained. LS 020110 EP14 has to do with the fire barrier penetration seals. So again, what we're finding here is unsealed or unfilled penetrations in fire barriers or fire-rated walls, unsealed, improperly sealed cables, etc. What I would tell you that you will start seeing is, depending upon which barrier this is, as these barriers move across smoke compartments, you will find now that those findings will be moved further to the right on the safer matrix to address potential risk to a number of patients that could be affected. In addition to that, I think it is really important that we also ensure that we have good above the ceiling activity going on as well. LS 020135 EP14, NFPA auto extinguishment, making sure that we don't have obstruction of fire safety equipment, gaps in penetrations in ceiling membranes, and misalignment malfunction of fire safety systems, making sure that the auto extinguishment equipment is properly maintained, that it's kept up to date, and that it's working appropriately. So in closing, there's a statement that I think is important that it really addresses almost every finding that we have in the report, which is know what your policies say and make sure you can validate you do what your policies require. Thank you for your time. I'm going to turn it over now to my colleague, Mark Crafton, to do his part of the presentation. Mark.
Thank you, Robert. If I could just get somebody to verify that you're seeing my screen adequately.
Yes.
Great, thank you. So I did want to start with a conversation about healthcare equity at the Joint Commission, because as I'm sure all of you who are acute care and critical access hospitals from the Commonwealth know that healthcare equity is a priority in the Commonwealth. And we are on the journey with you to bring not only the National Patient Safety Goal and the accreditation program across the country, but the rollout of the certification program, which all of you are embarking on, again, if you are an acute care and critical access hospital. These are the National Patient Safety Goals and the elements of performance related to healthcare equity. All of you went through this back in 2023, either during your triennial survey, if you had one in 2023, or a special one-day evaluation of these elements of performance that were conducted pursuant to the Massachusetts 1115 waiver program. You'll be pleased to know that now that this national patient safety goal has been rolled out nationwide, we continue to see really great compliance with these foundational elements of healthcare equity. You know, Robert talked about some elements of performance that were non-compliant 81% of the time, 70, 69% of the time. For the organizations that are undergoing this evaluation on this national patient safety goal, compliance with these EPs are non-compliance is about 1%. So 1 out of 100 hospitals has one of these where they do receive a requirement for improvement. Sometimes it's because they have not yet identified a leader, an individual that is designated to lead healthcare equity efforts in their organization. Element of performance 2, and I'll just summarize what each of these require of organizations. Number 2, again, very foundational, requires organizations to identify an area of your organization or a population in your organization for which a health-related social need is assessed. And again, we're talking about pick one health-related social need. Could be housing insecurity, food insecurity, could be transportation issues, difficulty paying medical bills. You get to choose which need is assessed, and you get to choose which patients for which that health-related social need is evaluated. That can be maternal patients, it could be patients with diabetes, could be patients from rural areas of your community. There's just a lot of flexibility built into these foundational accreditation elements of performance. The third one is, pick one quality or safety metric and stratify it against a socio-demographic characteristic. Again, it could be procedure or a clinical condition such as diabetes or childbirth, or it could be things like readmissions. It could be length of stay, could be mortality. Again, there's lots of flexibility in what quality measure you're selecting in the accreditation program. And then 4 is to simply create an action plan to address that disparity that you identified in one of your clinical and safety quality metrics, and what you plan to do to address it, and then do a PDCA cycle. And if that action did not result in improvement in the disparity, adjust and try something different. And then the final one was to keep internal stakeholders informed. So again, people are doing very well on the elements of performance related to the healthcare equity national patient safety goal, not just in Massachusetts, but throughout the country. So I just want to pivot a bit to the certification for healthcare equity. And again, this impacts the Commonwealth really more than anywhere else in the country. So it's important that you get a good understanding of what's expected. And I know over the last 2 years, we've done several webinars and provided resources to all of your organizations on each of these 5 chapters in the certification manual. And I just want to bring to your attention some of the differences between the accreditation elements of performance and the requirements in the more robust certification program. Under leadership, you not only need to have identified an individual that's responsible for healthcare equity work in your organization, but healthcare equity needs to be a part of your organization's strategic plan, or at least have an independent strategic plan on healthcare equity. And then secondly, there needs to be board level approval and involvement in your healthcare equity work. And that includes the board allocating financial and human resources to conduct the work required to help improve healthcare equity. Under collaboration, there is an expectation in the certification manual that speaks to outreach and development of collaborations with community partners. We all realize that hospitals alone cannot address all health-related social needs of the populations that you serve. So it's important to have linkages to your communities and the groups that are out there that can help provide resources. Some of those may include food banks to help address food insecurity. There could be faith-based institutions that provide support, organizations that help provide transportation to medical appointments, and organizations that provide assistance paying for utility bills to get that heat turned back on. And I'll share a story with you that I heard when visiting an organization who recently achieved our certification. They had a patient who kept coming into the emergency department almost every month, and they would evaluate this patient, and they really couldn't find anything clinically substantive about the patient's condition. Finally, they asked the patient, what brings you to the ER, once a month? And the patient said, I'm cold. It's very cold in my apartment. Well, why is it cold? And the patient, proceeded to tell them that the utility shut off the heat because he didn't have the money to pay the bill. So, the hospital, identified that as really the fundamental root cause of that person repeatedly coming to the emergency department. And the hospital got in touch with the utility, and for $300 got the individual's heat turned back on, got him connected to a community resource that helps people struggling to pay utility bills. And they probably, they would say that they save tens of thousands of uncompensated care dollars because they identified a health-related social need and engaged the community to help meet that need. I think that's just a great example of how healthcare equity and identifying health-related social needs it really is a safety and a cost issue. Data collection, there is the expectation that organizations collect data from its community about the needs, the health needs of the community. A lot of people can fall back on the tried and true community health assessment that is required of many nonprofit organizations, done in collaboration with community sponsors and partners, and that works most of the time. But sometimes we have found that community health assessment doesn't look like it's really tailored to the community. If you are looking at a health system, and the health system has both hospitals within medically disadvantaged, socioeconomically disadvantaged communities, that health assessment for that community should look different than the community health assessment from a more affluent suburban area. So make sure you're not trying to use the approach of one community health assessment addresses all of the different communities that you serve. On provision of care, instead of just screening patients in one unit for one health-related social need, the certification program requires that all patients are screened for health-related social needs. And if they screen positive for one of the customary social needs, again, housing, transportation, food insecurity, utility, difficulty paying medical and pharmaceutical bills, that you provide or refer them to community resources when that health-related social need impacts the patient's ongoing care. So, for example, if you have a patient with diabetes and needs, tight control over their dietary consumption, you should be able to provide referrals. If you can't provide that support yourselves, provide referrals to organizations in the community that can help provide the appropriate nutritional support that you've identified as a health-related social need. And then finally, in performance improvement, instead of just picking one measure of quality or patient safety to stratify by socioeconomic demographics, the certification program asks you to identify at least 3 quality and safety measures and stratify them by disparities. And there's lots of examples of different types of quality metrics, again, maternal, cardiovascular, readmission rates. There's just a host of things that can be stratified. And remember, some of your sociodemographic characteristics may include rural patients who may have transportation issues, getting access to care. It could be elderly patients are part of your stratification. It could be individuals who have status as a veteran of the armed services. So there are a variety of different characteristics that one can use to meet the requirements in the chapter. So as I mentioned, all the acute care and critical access hospitals in the Commonwealth will be undergoing this certification in 2025, hopefully prior to the end of September 2025, because we want to make sure that all organizations have that 60-day evidence of standards compliance should a requirement for improvement be identified. But I wanted to just give a shout out to these 3 trailblazer pioneer organizations who raised their hand in 2024 and said they wanted to complete the healthcare equity certification. So I know you're going to hear from Anthony at Lawrence General. So just a shout out to not only his organization, but the good folks at South Coast Hospital Group and the Dana-Farber Cancer Institute for being early adopters. So I know you're probably going to have questions about healthcare equity certification that we'll get to in the Q&A, but I did want to just spend the last few minutes that I have with you to talk about maternal levels of care verification, because I think that this could be the next thing for the Commonwealth of Massachusetts to be thinking about in terms of directives. We know that it was about 13 months ago that the Massachusetts Department of Public Health issued an announcement that they would be starting the process of designating the 40 birthing hospitals in the Commonwealth by maternal levels of care. And I'll be honest, we haven't heard any subsequent details about what that designation program by the Commonwealth will entail. We don't know when it will start, what timelines are there, but I just think it's good to be prepared. And so we wanted to bring you just some content on the maternal levels of care verification program that we have prepared in conjunction with the American College of Obstetricians and Gynecologists. So our maternal levels of care verification program, again, was developed by evaluating the ACOG and the Society for Maternal Fetal Medicine's guidelines on different levels for maternal care. We had to make some adjustments to put them into a kind of requirement that one can score and be evaluated on. But it's fundamentally that consensus statement from ACOG and the Society for Maternal Fetal Medicine. And we did add some additional quality improvement measures or standards because we are the Joint Commission and there should be quality improvement aspects in virtually everything that we do. These verifications are conducted on site and they're typically one reviewer for one day. Maybe for the largest level 3 or level 4 organizations, it might be one reviewer for 2 days, depending on the size of the organization. Unlike most of the certifications that you're familiar with, including healthcare equity, maternal levels of care verification is on a 3-year cycle because that seemed to be the time frame that most states were following when states had developed their own state-run designation program. It was a 3-year state visit, so we wanted to be in alignment with what many of the state regulatory agencies do. And just like healthcare equity certification, maternal levels of care verification is open to any acute care and critical access hospital that's Medicare certified. Organizations do not need to be accredited by the Joint Commission to be eligible to go through the verification process. These are the four, what I call the 4 rights that really are the foundation of our maternal levels of care verification program. Right resources, right staff, right equipment, and right processes. One of the things that we find when we look at organizations that have gone through the process is that this really isn't assessment of the quality of care delivered. It's really more foundational than that. Do you have the staff as described in the standards for verification and the consensus statement from ACOG? And a good example is, people will say, yeah, we want to be a level 3. We want to be a level 3 maternal care center because that's what we think we are. We treat pretty complex, high-risk pregnancies. We're a level 3. But one of the elements of maternal levels of care verification, if you want to be a level 3, is that you have a board-certified OB/GYN physically present in your organization 24 hours a day, 7 days a week. And some organizations are they're sure they're a 3, but then when they look at it closer, there's a period of time, either in the afternoon because people are in their offices seeing patients, or it's in the middle of the night, but there's a period of time that they don't have 24/7 OB/GYN coverage. That doesn't mean that they're a bad organization. It doesn't mean they aren't able to treat serious complications, but they simply don't have the staffing that qualifies them for a level 3. They would be a level 2, and there's nothing wrong with a level 2. Level 2s can treat moderate to high risk pregnancies, as you'll see in the next slide. Right resources. Some organizations, have all the appropriate coverage of OBGYNs. They have all 24/7 board certified anesthesiologists, but they found out that on some nights their blood bank only has 4 units of blood. So if you are an organization that has trouble having an adequate amount of blood, you really aren't best equipped to prepare for some unexpected high-risk complication that involves maternal hemorrhage. So you got to play all these against each other to find out what level organizations would fall in. And the other thing that I'll mention is that it's really, I'll go to the next slide. It is difficult to say what clinical conditions are falling into level 1, level 2, level 3, level 4. Obviously, level 4 is designed to address every surgical, or every maternal condition and complication because they are appropriately staffed, have the right people, policies, and resources. But when it gets to level 2, level 3, people would want to say, okay, if we have placenta previa, can we do that if we're a 2? Or if we have placenta accreta, can we do that if we're a level 3? And it's difficult to make a black and white call on maternal conditions and put them into certain levels because it's more complicated than that. It depends on your staffing, your resources, your processes. So ACOG has cautioned us into trying to say, this level can do these kinds of cases. Instead, we provide a set of requirements that really describe the different levels and expectations in terms of people and resources. Here's an example, one example of how the level 1 through level 4 really layer on each other. So this is the expectations around imaging services, and it doesn't describe it, but level 1, the most basic foundational organizations that are still delivering babies. They need to be able to do non-obstetric ultrasound imaging. And that's pretty much the only imaging expectation for level 1. When you get to a level 2, you have to not only be able to do that, but you must be able to provide obstetric ultrasound imaging, CT scan, MRI, and maternal echocardiography. If you look at a level 3, they need to be able to do all of the things that the level 2s do, plus be able to provide specialized obstetric ultrasound and fetal assessment, including Doppler studies readily available at all times. So these all build on each other. The requirement for anesthetic providers and their expertise builds from level 1 up to level 4. The individual responsible for obstetrical services builds from family practitioners in level 1 up to maternal fetal medicine specialists in level 4. So that's a quick review of all the content that I wanted to share. This is our fundamental disclaimer slide. that we put in all of our presentations. You'll have that. And I tried to find a Kelly Green question slide in honor of the Boston Celtics for all of our friends in the Commonwealth. So that concludes my remarks, and I'll stop sharing the screen, and I think we have some time to take some questions.
Yes, we do. Thank you so much for all three of you. That was really wonderful information. So we do have some questions in the chat, and apologies, some of these might need additional context, but let's go to the first question. So first actually just looks like a comment. They experienced the new safer matrix with the addition of the standard and EP info at their recent triannual survey. Great improvement. Also, the new design of the report with the findings and order of severity are also very helpful change. So thank you. So first question, and from the timing, I'm not sure if this is for Dr. Mort or for Robert, but is the conditional level tag applicable to the substandard, i.e. B2?
Yes, thanks, Kim. I should try to go in and I couldn't hit each one to respond, but so B2 is the parent of a child of a parent tag. So for example, you may have 482.23, which is the parent regulation, and then it has subparagraphs below that. For example, 482.23 B2. So B2 may be attached to a particular Joint Commission requirement, but we have to assess the parent tag. So we look at everything under 4223 that's been attached to the parent tag. So yes, it is possible that you would have a condition, but if a child tag is conditioned, then the parent tag must be conditioned, meaning everything under that particular condition of participation is a condition level.
Great, thank you so much. And I think the next few questions might be for you, Robert. So does the SharePoint site allow PHI such as census?
At this time, no, we would not put the census on there. It would just be for policies and procedures.
Thank you. And at the end of the survey, is the document upload folder not available for the surveys only, or the hospital also cannot access their previously submitted documents?
At this time, it comes down completely. We're still working with CMS to get some further guidance if we can leave it up for the hospital, but at this time, it comes down completely.
And is this live for organizations surveyed in 2024?
That was for benchmarking, and the answer is yes.
Excellent. Let's see, does the benchmarking tool factor in number of surveyors and not just number of days of the survey?
It takes both. It takes number of surveyors multiplied by the number of days they're there. So if you have 3 surveyors for 4 days, it's 12 surveyor days.
And this one I already answered. The general question, will slides be available to participants? Yes, we will be sending out the slides to everybody. So, okay, and on the safer benchmarking, does the bed number include emergency department beds since they are not on our state license?
It goes off of the number of licensed beds that you have.
Okay. And could you share best practices of titration and block charting in an ED setting? That is a common area of struggle.
Yeah, so it may be good for us to have another session. I could spend the next 30 minutes talking about that. So, I'll work with MHA to see if we can do a separate session on that particular piece.
Great. Okay, and I believe the next couple of questions are for Mark. And this one, I'm not positive what it's referring to, but it's asking, do those have to be hospital-specific measures or can they be system-wide?
So I can actually take that one.
Oh, I'm sorry. There's
Oh.
clarification from the person. So the above question is regarding the health equity certification. Do the safety quality measures have to be hospital-specific measures?
So the answer is yes and no, meaning each accredited organization has to do an assessment of the patients they serve in the communities they're in. Now, if it so happens that all the hospitals in that system did an individual assessment at each organization and it's the same, then that would work. But we're going to look for evidence that each individual location within that system has done their own assessment for the patients they serve and the communities they serve.
Excellent, thank you. And if there's any additional questions, we do still have a couple of minutes if you want to get those into the chat. Oh, we've got one more. Can you clarify a bit the process of the collaborative call? Is that an unbiased person looking at an issue?
Yes, it's a member of the standards interpretation group. So it's a member of my team who will get on the call, who will ask the surveyor to explain what they've seen and ask the organization to share their perspective so that we can make sure we've heard both sides, and then we will make that final decision. I would tell you it's about 50-50. Half the time the finding doesn't go in the report, the other half of the time it does. So if there's ever a concern of some type of bias, then that needs to be reported to myself so that I can evaluate it and investigate it.
Any other final questions before we move on to our next speaker?
Kim,
And you can put,
Kim,
yes,
if there are no questions, maybe I would just like to make a comment.
please.
Number one, thank you and the MHA for inviting us to participate. And I just wanted to give a shout out to Robert and Mark. I started the kickoff of our comments today saying that I was relatively new at the Joint Commission. I used to be someone who would be on this webinar as opposed to giving the webinar. And I never really knew what went on at the central office. You know, the central office was a place where occasionally you had to make a call during the triennial survey because something wasn't going well. Now I work at the central office with people like Robert and Mark, and they really dedicate themselves day in, day out to ensure that the surveys that we provide you and the new certification programs that we develop are meeting your needs and trying to make it easy for you to adopt these new certifications, comply with the surveys, but also to support you in your journeys to improve care, make it safe and high quality for all patients. So thank you very much, Kim and colleagues, for inviting us.
Yes, thank you, all three of you. Wonderful, wonderful presentations, really rich information. And thank you to the Joint Commission for your continued advocacy and focus on patient safety, patient quality of care, and really meeting the needs for everybody, all patients. So thank you all. And next, we will move on to our next speaker. I'd like to welcome Anthony Alley, Senior Vice President, Clinical Operations and Chief Nursing Officer and Chief Quality Officer for both Lawrence General Hospital and Holy Family Hospital. Anthony will be sharing his and his team's journey to achieving the Joint Commission Health Equity Certification. This work is more important than ever, and I know MHA is continuing to collaborate with all Massachusetts hospitals on this critical work as both part of the Joint Commission certification as well as the Health Equity Medicaid waiver. So thank you, Anthony, and I'm turning over to you.
Thank you, everybody. Please let me know if you can see my screen.
Yes, we do.
Yes?
Yep, looks good.
Okay, great. Thank you, everybody. Yes, thank you for having us here today. It's been quite a journey for Lawrence General. I think that just to give a little perspective, well, Lawrence General is a gateway city, one of the poorest cities in Massachusetts, certainly the largest community of color. We have about 90,000 residents. 82% of the residents identify as Hispanic, with 41% being foreign born. Limited English proficiency is common. 80% of the residents in Lawrence speak a language other than English, and more than 30% of the adults over 25 years of age have less than a high school equivalent level of education. More than half of the city's residents rely on Mass Health for health coverage. And Lawrence has more than double the percentage of residents with no health insurance compared to the state. Most notably, Lawrence has a per capita income of only $23,000, which is less than half of the state average of $48,000. So certainly we are a safety net hospital serving one of the poorest and underserved communities again in all of Massachusetts. That said, the journey for health equity began at Lawrence General quite some time ago. Health equity, diversity, equity, and inclusion has been a pillar in our strategic plan since 2020. So we have been, again, on this journey for quite some time. And that said, still, the certification was a process, and I want to go through some of those highlights. I know we have a short amount of time, and there was a lot of material that I shared with MHA that we will send to all of you after this meeting, including opening presentation, our data presentation, copies of our agenda, tips of the week, some staff education. So I sent as much of the material as I possibly could. I also know that I've reached out, and many of you have reached out to Angelique Blodgett, who is our Director of Accreditation and Regulatory Compliance. And we have and will continue to assist any of you in your journey as well towards certification and health equity. So please continue to do so, and we will continue to support as much as possible. So that said, I hope we are advancing. I wanted to talk a little bit about a timeline, and I think this was something that was important for us. We took this 6-month kind of time frame from a previous certification. We earned our primary stroke certification through Joint Commission prior to the health equity, and we learned from that experience that a 6-month time frame worked for us. That timing of preparing the gap analysis, the staff education, leading up to day of survey. So for us, for health equity, our survey date was September 17th. We started the gap analysis in March using the Healthcare Equity Certification Standards Checklist from Joint Commission. We started that with our DEI committee, which again, we meet on a monthly basis. That committee has been a standing committee for quite some time, very helpful in helping us understand where the gaps were and where we needed to go. And I think for us, we realized quickly it was around policies. So although we were doing the work and it was part of our culture, it wasn't written. And so we spent a lot of time in April doing the policy review, drafting those policies, bringing them to leadership, back to the policy committee for approval, and then, of course, having to educate the staff. That took a little bit, I think we have here, the month of April, but that was a process. And those are part of the required documents. In May, we went back again for the second time, and we looked at the checklist one more time and realized that with the certification, you have to have a minimum of 4 months of data. Knowing that we put September as a readiness date for us, we knew that May was the month that we had to start looking at the data that we would be presenting at the time of survey. So that was important to make sure that we had everything aligned with Meditech. Lawrence General was the first, at the time of the survey in September, we were I believe the 11th hospital or system to be surveyed at the time, and the first Meditech. And there's challenges certainly with Meditech. So I think we spent some significant time making sure that reports could be run, the data that we needed we could have, that we were able to stratify what was needed. And so we spent some time internally. I will say, we did reach out to Meditech, but it was our internal experts that really helped to build those reports that were needed for us to make sure that we had, again, the required data sets and documents. In June, we started our staff education. Our DEI officer, who has been in place since 2021, Virgilio Velez, began rounding. We use Centec. It's a rounding tool that leaders have on their phone. It's an app. We use it for many things. We use Centec for even our Joint Commission readiness for environmental care and life safety. We use it for patient satisfaction. We use it for employee satisfaction. And so it was Angelique's brilliant idea to do, a rounding tool for Joint Commission certification, health equity certification preparedness, to get a pulse of where we were with staff acknowledgement. And so we started that. We submitted our application in June, again, with the readiness date of September. We knew that's what we were thinking would be appropriate. And then in July, more education. We began some of the tips of the week. We sent out 7 tips. Again, I have sent all of those to MHA. Those will be available to all of you after this presentation. We started to run health stream reports to see where we were with the staff education on our DEI module. We started our final Joint Commission checklist, and we started to draft our opening and our data presentations. Again, those will both be shared with all of you after this. We received notice from Joint Commission on August 16th, so almost exactly 1 month prior to survey date, that the day would be September 17th. We also were given the bio for our surveyor on that date as well. And at that point, we started to finalize the agenda, and I'll go through more of the agenda in a moment. Again, this is, I think, where we started to do more staff rounding, more staff education. We built an education tool for the directors and managers to use on their units during staffing huddles. Again, I have included that in the material to be distributed. And we also started with the presentations, assigning the slides to different speakers during those sessions, doing what we called run of show, sending out those last tips of the week, and then, of course, finalizing those last bit of logistics. And then we had, of course, our survey on the 17th of September, and there was the document submission the week prior. And there were no, I think that was asked, but you do not submit any patient information, but you can submit your presentations if you have any, and I do recommend that you should, would go with all the required documents as well that week before the survey. For the minimum data, the presentations that we worked on for the data sets, what we chose, and again, this was said earlier, we do have a community health need assessment. We do it every 2 years, 3 years. We looked at what the needs of the community are, and for Lawrence, Merrimack Valley, behavioral health has always been, we call it a behavioral health desert. We hold between 10 to 20 behavioral health patients, not uncommon at Lawrence General. But now, being part of a system that we've built, I think many of you are aware that we've acquired the Holy Family sites back on October 1st. We have more access now to behavioral health beds, and how we expand that, not just for our own patient population, but throughout Merrimack Valley is, there's more to come on that. But we chose to look at 3 areas that we found, again, when looking at the data and stratifying data, that there were areas of opportunity. And for us, one of those quality improvements were readmissions based on interpreter need. The second was on perinatal care and C-section rates. And we chose that because the majority of our patients come from the Dominican Republic. And the Dominican Republic, the WHO, the World Health Organization, reported in 2021, at the time, has the highest C-section rates in the world at 62.9%. And we certainly see that here. It's a request from our patients. And then finally, we looked at mortality rates and how we stratified our mortality rates. So those were the 3 that we used to present in our data session. This was, again, where we started the journey, to see where that gap was. And I do want to point out, and I was reminded of this again yesterday, just to be mindful when you use the Healthcare Equity Certification Standard Checklist, the required documents are not included on this standard checklist. So please make sure that you look at the Joint Commission manual or go on the website to ensure that you know the required documents and that you have those prepared. They were not included on the standard checklist. So I just want to make that point again. But this certainly was how we identified the gaps and how we formed our subgroups, and how we brought back that work every other month, like I stated on that timeline, and how we prepare the staff. Again, this was part of our Centec rounding tool, asking, who's responsible for health equity? Do they know about the work that's being done? And again, it became almost like so part of our culture that they know the work that we do, but to them, it's everyday work. So it was almost like retraining them to be able to speak about the work that they do in a Joint Commission certification kind of way, because for them, this is just what we do and what we've always have done. So it was really interesting to get the response from the staff on the prep survey. And then this was the staff preparation tool that we gave directors and managers to use, again, on rounding. You'll all have a copy of this as well to help with that staff education. Tips of the week, there were 7 of them, like I stated. We'll have this for all of you. But again, looking at areas of opportunity, certainly we ask because we care. That was a campaign that we still, again, we kind of a national search. We kind of looked to see how are we educating patients. Patients that are coming in through the emergency room, the emergency center. Why are we asking these questions? How are we educating our community? So really working with our marketing team and our community leaders to help us with this campaign. We ask because we care. And it was, although more well-known in the emergency areas and point of entry, not so much on the inpatient unit. So we identified quickly that that was a gap. So we did a lot of education on that as well. So day of survey. The agenda is really for us. This was our blueprint. I think that this document was probably one of the most important for the team in preparation of the day of survey. We made sure that, and this is provided from Joint Commission, we made sure that we had the right participants at the right session, and we did individual run of shows with these individuals in these sessions. I know this may be hard to see, and again, you'll have this document. But not only did we run through a full day, but we also, like I said, ran individual sessions. I will say the surveyor that we had did arrive early. The survey was a full day. We started at 7:30 and we went all the way till it was after 4 o'clock. It was a full day survey and it was a working lunch. And the approach to the day of survey was very systematic. He absolutely went from this agenda that was provided step by step. There was no deviating from this agenda, I have to say. So we were happy that we put the time, effort, and the preparation into this agenda because it certainly paid off for us day of survey. So I would recommend that you look at this, that you make sure that you have the right people in those sessions, you plan accordingly. He did do his best, as we did as well, to stick to the time frame for each of these sessions and activities, and to make sure that the required documents are available for each of these sessions. Although they were sent previously, like I said, a week before, we did have 2 binders. I think Robert said it. You don't need to have everything in the binders. There's really no need to do that. It is not hundreds of pages, just the actual required ones, which aren't that many, available in the conference room, not just for the surveyor who may need something, quickly rather than have to log in onto the computer or desktop, but also for those participating day of survey, for them to almost have as a refresher as well. So we did have 2 binders available. These table of contents are also included in the distribution that you'll all receive. Day of survey. So as Angelique and I sat with the surveyor, our team was getting the list of active patients and discharged patients and RLs available to bring up for our 8 o'clock opening session. Joint Commission will have a short presentation, and then you go right into your opening presentation, which I will say, I think is probably the most important part of the day. it sets the tone, it tells the story. And I always say it's about telling the story. I think that, again, if you look at the agenda, the opening orientation agenda clearly outlines 7 elements, and these are the 7 elements. And so whenever there was a session that required a presentation, the orientation or the data, we put together an agenda. We highlighted again what was provided us from Joint Commission, and we ensured that we had met all of those requirements, right? So it's almost like doing that mini gap analysis and making sure that you are compliant with the ask. And so for us, and I'm just going to highlight a couple of things on this opening. I think some of you may have seen this in the past. For us, again, it was just about tell who you are, talk about the community that you serve, the patients, and why health equity is important. I spoke to you about the city of Lawrence. You can certainly see for us our payer mix and how challenging that is for us. Despite that challenge, how we continue to excel in quality and patient safety. Again, I will say, since this was the opening presentation, we have since not only earned our Joint Commission primary stroke, we have earned our health equity. And one thing that was interesting on our health equity journey, as you go through the health equity journey, you will notice that there's a lot of tie into sustainability. And so I have to say, we did earn our Joint Commission sustainability, healthcare sustainability certification. Again, one of the first, I think we were the first in Massachusetts and in New England just this past December. So I'm sure I will have the opportunity to share that with all of you in an upcoming session as well. As you know, there is more standardization and requirements with the missions this year, and more so, I think, in the upcoming years, not only with Joint Commission, but with Mass Health. So we'll have the opportunity to talk about that in the future. Talking about, I believe, we heard from Mark about, the leadership and the support. You can see here that DEI is one of our 5 committees. It serves as an advisory committee to our full board. There is that level of support, our trustees, our CEO, making sure that we represent our staff, our leadership represents our community. I think we have done a tremendous amount of work in the last couple of years to make sure that that is happening, and it is a priority for us. This is our strategic plan. Health equity has always been, like I said, part of our strategic plan since 2021. It is one of our 5 pillars, one of our 5 E's of excellence. The financial, I think somebody had mentioned this as well, is the organization committed to the resources and the allocations. We went through these with our surveyor in our opening, again, this orientation in a little bit more detail to talk about the commitment and resources to health equity, not just through grant funded activities, but also through the board and our annual budget as well. Our multi-year DEI improvement plan. And then this was one of the takeaways actually from our 2022 Joint Commission survey as well. This DEI metrics and goals was a takeaway from our triennial survey and again at our health equity survey. This was one highlight that the surveyor said, something that we should publish, that they had not seen, he had not seen. He had done 9 surveys, 9 out of the 11 surveys at the time of our survey, and had not seen metrics and goals in a format such as this. And this has been a format that we have used for quite some time now and continue to do so. And you'll have this in the handouts. Again, information on We Ask Because We Care. This is at our entranceways for patients to see. Handouts that we give the patients. And then it gets into some of the requirements of the orientation. We talk about the patient and population, community demographics, race and ethnicity. And it's all about how you present the data as well, right? Is it in a meaningful way? Is it something that, is understandable and relatable to the audience? This was something that was presented and provided a week before. So that's important to note. The questions he had, were prepared ahead of time. So we didn't know, but the surveyor knew. He knew that on slide 32, he would say, pause, I have questions on this slide. So I do think that, again, sending the presentations ahead of time, they have the opportunity to look at the material. And so you have to be prepared to answer the questions. This is our community health engagement calendar, all the events. We went through this, not just this 2 months, but we looked at actually several months of community events. And this was the second takeaway. We do have a community health needs van. We call it our Health on Wheels. This was part of a donation through local benefactors and Herb Chambers. This van is used at marketing, food markets, health fairs, community events. We do free blood pressure screening, education. We talk about health insurance. We connect patients with, mass health applications, with primary care physicians, and really spend a lot of time talking about our story, about how we are out there in the communities. So going out to the patients rather than them having to come to us. So this was the second topic that he said, or recommended that we do some publishing, which we are working on. And then we got into Meditech. And so this was interesting because, again, we were the first Meditech organization that he had seen. And so how did we get the data and how are we stratifying? So we spent a lot of time on Meditech. And so for those of you that are struggling with Meditech and how to stratify that data or how to build the queries of the reports, please, again, reach out to us. We're more than happy to show you how we did that in greater detail. SNAP rounds. This was a recommendation. I will say we had no findings on our survey. We were the first out of his 9 surveys to have no findings, and we're certified day of. We're very proud of that. But we had some recommendations. This was one of them, multidisciplinary rounds. He did recommend that our DEI officer attend the daily SNAP rounds, which we have made that change. And then it was all about referrals and community resources. How are we doing that with how patients are scoring on a health-related social needs assessment around homelessness? We spent some time on that. Again, the handouts that we give our patients, all of the collaborative work that we are doing with partners in the community. And then, the screening, again, getting to that 100%, that was mentioned. You have to show that you have that 100% of screening. And then we got into some work around disabilities, which, part of the survey, it is almost like a little EOC life safety survey. There is, the disability, can patients get into the doors? We looked at emergency room doors. Is there a way that if somebody's in a wheelchair, do they have access? Is there a way for them to enter into restrooms? We looked at signs that we have in Braille. We looked at things for patients that have difficulty with hearing. We looked at, the canes, wheelchairs. I mean, I want to be clear, I think that some people were not prepared for that conversation I've had. Some of you have reached out, but disability is part of the survey. I think that people are not paying attention to that. So please be mindful of the work that needs to be done and the collections around disability and how you're addressing when patients answer yes or no to those questions. And then we got into some policies, which I told, like I stated at the beginning, April, we spent a lot of time on policies, and then actions around how we are diversifying our job candidate pool. Complaints, we spent on bias, patient perception through RLs, and how we're closing the loop, and the education we are doing on making sure that we are addressing incidences of staff perception on bias and discrimination. So I do think that it set, like I said, the tone for the day. And certainly, I think it's worth spending time and effort on that opening survey session PowerPoint presentation. So I'm happy to take any questions.
Thank you so much, Anthony. This was a really fabulous presentation. It looks like there are a couple of questions in the chat, and just a reminder, if anyone would like to ask questions, we do have a few minutes. First one, surprised to see that in 2024, the Joint Commission required document upload a week prior to the survey. They're requiring documents to be uploaded 45 days prior to the go ready date. This is before the survey date is received. So I'm not sure if that's a question or a comment.
Yeah, I think for us, and maybe that has changed again. We were an early adopter. You know, I think we were the 11th in the country. I think the second in the state, the first standalone hospital. We got notice. We were surveyed on September 17th. We got notice from Joint Commission on August 16th that the 17th would be our date. This is your surveyor. And we heard from Joint Commission about 3 weeks later, week before survey, to upload the documents. So that's how it worked for us. It may have changed. I don't know if Dr. Moore or anybody from Joint Commission knows if it has since then, but that was our experience.
Thank you. And second question, was this all part of the opening conference? And can you also talk a little bit about the live tracers?
Yes, so that was part of the opening. And so yes. And so I will say that, again, following the agenda, it was right to, again, very systematic. And so we did have live tracers on the units. You have to provide the morning of the survey, that patient list, and he will go through that. The surveyor will go through that list, identify a patient. Of course, you have to ask the patient if it's okay, if they're able to speak to them. But, you know, patients that require interpreters, patients that may be hard of hearing, patients that may have answered yes to a disability question on this on the admission assessment for disability needs. So, and then there's the conversation and looking at how the documentation is in Meditech and what you are doing to address the need. So for us, we have, there was a patient that's hard of hearing, and we do have amplifiers that we provide those patients because we don't like to have patients keep hearing aids in the hospital. I think we all know we have a habit of losing those. So we do have amplifiers that we do give patients. So that was something that we discussed as well.
Thank you. And it looks like there's a follow-up to that question. Did they ask staff any questions about your health equity strategy?
Oh, yes. They ask about education. They want to know about, you have to show them the education module that you use. They want to see the compliance with staff education, how many have completed that. They ask the staff about how education is, how often. They do ask about, you know, activities that the hospital is working on with health equity, how we promote health equity. Will say the surveyor will tell you also when it comes to the human resources record chart review, they will pick 6 employees for review. And it was not a nurse, you know, it was EVS, it was case management, interpreter services. So again, you know, I'm happy to have those conversations with folks.
Wonderful. Well, I don't see any more questions in the chat. So
Kim,
yes,
it's Liz Mart.
Please go ahead.
Congratulations, wonderful presentation. Thank you for being an early adopter and sharing. The question about the documents, I'll have to send it back to the team who weren't able to stay on, and I'll get back to you, Kim, so you can post it in the chat. I personally don't know.
Okay, very good. Oh, looks like we've got one more question. Did the surveyor visit the ED or PACUs?
ED, I will tell you the ED is key. The ED is key, and that was repeated that over and over throughout the day. That is your entranceway. That is the entranceway, the doors to your organization. and that there should be focus and attention to training and education of that staff, which of course we do that, and that was appreciated. But I will say that that was something that he has not or finds lacking in other surveys that he had done. Again, he had done 9 out of the 11. So I will say spend time with your ED staff and environment. So making sure that you have signs that are bilingual, have things that are available. I don't know if they need to be in Braille. We have bathroom signs that are in Braille as well. Making sure that, again, for us, disability, do you have, do the doors automatically open? If not, is there a button for if someone was in a wheelchair that they can press for the doors to open? Look at your environment around the ED. Is it accessible for those that are disabled? And is it in a way that is inviting, non-discriminatory? I will say he will spend more time in the emergency room, if it's the same surveyor, don't know. But I would say spend more time preparing your emergency room staff than any place else.
Thank you.
No visit in the PACU.
No visit in the PACU. Okay. Thank you so much, Anthony. We really appreciate your commitment to this work and appreciate you sharing with everyone else here today your experiences for Lawrence, and congratulations on earning certification.
Thank you very much.
You're welcome. And so now we're coming to our final session. We have 3 hospitals who are going to be sharing their experiences from the field when it comes to survey readiness and results. We will do question and answers after each hospital's presentation. So we'll do 3 separate Q&A sessions, one for each hospital. First up, we're going to have Erin Donovan, Vice President, Quality and Regulatory Compliance from Tufts Medicine and Lowell General Hospital speak. After Erin, we will have Laura Sims, Senior Director of Quality and Risk for Athol Hospital and Haywood Healthcare, along with Jody Larson, Chief Quality Officer and VP Quality and Safety. Jody Longloy is going to join Laura Sims, Director of Risk for Athol Hospital and Haywood Hospital. And last, we will have Jody Larson, Chief Quality Officer and VP of Quality and Safety at Boston Medical Center, along with Sandra Montrond, Director, Accreditation and Regulatory, Boston Medical Center. So thank you, and Erin, take it away.
Thank you so much, Kim, and good afternoon, everyone. I'm delighted to be here and share with you a little bit about our experiences that we had last year with our triennial survey. So if we could go to our next slide. Just to give you a little bit of background on Lowell General, I'm sure many of you all know where Lowell is, but we are a large, complex community hospital. A little over a decade ago, we merged with Saints Medical Center. And so we added to our bedside. We're now considered one hospital with 2 campuses. And so we have about 400 licensed beds. And we have 2 emergency rooms, 1 at each campus, with about 90,000 ED visits a year. We also have a number of outpatient centers. There are 11 ambulatory sites in total. And that's a combination of patient service centers in the surrounding communities, weight management center, wound healing, rehab, anti-coag, and a couple of other clinics. Next slide. So just a couple quick survey details. We had a fairly large survey team. We had a total of 7 people come. We had 3 nurses, one of whom was the team lead and served as the administrator. We had 3 physicians, one of whom served as the ambulatory surveyor, and 1 engineer. And I will say the preceptee rather, had been a former Joint Commission surveyor, had stepped away for a couple of years and then came back. They were a very, very strong team, very seasoned leaders, former CNOs, CMOs, chiefs, We were very impressed with their knowledge and scope. So we were fortunate in that team. They were spot on, and we had a good relationship. We were able to build a very good relationship with them. We were last surveyed in 21. And so we had been expecting the survey to happen in the late summer, early fall, but they actually did come about 2 months early for us, right after the 4th of July holiday week. But we were ready. Next slide. So I'm going to spend a lot of time talking about our preparation, because I really think our preparation was the key to our good results. If you go to the next slide, I'll start reviewing some preparation activities that we took. So about 18 months ahead of when we were due for our survey, we really started gearing up our preparations. We always have a state of continued readiness, but we started to kick it into high gear. We found it very helpful to have a practice survey. And so we happened to engage with Patton to do a clinical survey for us. And then we also have management services for our EDS and hospitality services through Sodexo. And they have services to come in and look at the physical plan and the environment of care. We absolutely took advantage of those. And we found that so helpful to have, you know, a 3-day survey ahead of time to help us identify opportunities, gaps that we had. It was helpful to understand what changes had occurred from our last survey. Certainly we get those notifications from the Joint Commission, but they had that sense of how it's being applied, what hospitals are running into with issues, and so on and so forth. And it allowed us to put together a work plan for the next several months. We also use this opportunity of having outside surveyors come on site to really get our escort team practiced in taking our surveyors around and going through the typical survey activities. So we have a monthly quality committee called the Performance Improvement Council. It's a great committee with strong representation from our clinical service line leaders, as well as senior members of our medical staff leadership. And so we would bring all of our survey readiness activities to this body, along with the corrective action plans and all the improvements that we were undergoing on a regular monthly basis. For additional continued readiness efforts, we have a regulatory compliance specialist, and you're going to hear me refer to Christina many times. She is that person. She is an exceptional clinician and knows these standards inside and out. But she took the time to round specifically with clinical leaders, especially at the mid-level, middle management level. Those people at the clinical leader level or the clinical manager level, and walk around units, helping to point out what she sees, looking through the lens of a surveyor. Because so much, as you know, like, you just don't see it anymore when you live in that space all the time. Members of our safety committee do environment of care rounds regularly. Those continued. And then our infection control team, even though they're part of the environment of care rounds, they started a program called Spring Cleaning. And again, it was going to every single unit and clinical area and really doing a deep dive walkthrough with the leaders in those areas and letting them see what they see from an infection control perspective. I'm sure many of you have daily safety calls. We use those as well, our daily safety briefing, to focus on quality of care issues we were seeing from a readiness perspective. And then I know documents has come up several times. We had actually had a recommendation from our consulting firm to, rather than put all the documents into a binder, consider using hanging folders, so that we weren't taking a binder out of commission when the surveyors were looking for them. I know there's a big shift to electronic, and it was very interesting to hear Robert talk about that earlier. I still feel some people really like the paper, so we'll probably do both next time. But we did have all these ready to go in my office, which is steps from the meeting room. And this was very important because I could just whisk it directly there that first morning. Can we go to the next slide? So I will say that probably many of you are experiencing what we have, is in that we've had a lot of turnover of staff and many new staff. And so we really were at a period where we had to do a lot of educational staff. Many of them had never gone through a Joint Commission survey. And so we really needed to do a lot of basics in terms of what is the survey, what does it encompass, and so on and so forth. So Christina, again, pulled together these weekly flyers that she would send out. And they were just a one-pager. We tried to chunk the information for staff rather than bombard them with a lot of information. And you can see a list here of some of the different topics that were covered through these weekly flyers. Again, probably some of you may struggle with this, with people reading their emails. We do have a process where the clinical manager prepares a weekly email, what we refer to as a Friday flash, and staff do tend to click on that one. And so we often embedded this information or added this information to those Friday flashes to get the word out. Can we go to the next slide? So we wanted to also think about our geography. So I mentioned that we have 2 hospital campuses, we have 11 offsites. We have a lot of different units, like over about 50 units or clinical areas that we knew surveyors were going to go to. And we had 7 people rounding. So that's a lot of eyes on the place and a lot of footsteps that they're taking. So it's easy to find environmental things when you have that kind of layout. And so we did spend a lot of time preparing surveys and develop it using a rounding tool. We also use Syntax, which we find very helpful. And we focus these surveys on those things that typically trigger as an RFI: environmental care and infection control, national patient safety goals. We set up a process where we had 2 surveys go out every week for our leaders. While we had our standard rounding processes going, as I described earlier, we really wanted to move that information down to the manager level and even to the staff level. So we set up 2 surveys to go out every week, with all of them to be completed within a month. And you can see we started that in late 2023 and continue that up through survey. We've since backed off of those, but we do get into that cycle of, continued readiness, ramping up as you get close to the survey, and then starting to back down a little bit afterwards. You can see we had very, very strong compliance with this process. And I really think that it helped ground and again, continue that education process with our new leaders, relatively new leaders and staff. We also were able to put together dashboards with the information from this. And if you go to the next slide, you can see an example of what that dashboard looked like. This was, you go to the next slide. Thank you. This was an example of 2 surveys that were focused on national patient safety goals. On the bottom, you can see the different questions that were asked of staff to see how if they were able to answer these questions. And the lighter blue tone shows that they were able to answer them effectively, and the darker blue shows that they had trouble answering. So these were very, very helpful in helping us understand where we might have to focus additional education in certain areas. And we were also able to break it down by clinical area or by unit. Again, to offer further support to managers, go and visit, do more on-site training, and so on and so forth. So as always, data, particularly from the data. Go to the next slide, please. We also have regular monthly leadership meetings, and these leadership meetings consist of, the president, the vice president, directors, managers, supervisors. It is anyone in a leadership position. And we really try to use these very effectively. Every month I will get up and talk about the joint commission and our readiness process. As we have new staff, we have new leaders too. And again, many of them had never gone through the Joint Commission survey, so we knew we needed to give them a lot of support as well. You can see examples of some of the slides that I shared at the leaders meeting. The top one really is from the findings of our rounding efforts. The one to the right of that, many of them had never seen a safer matrix before, didn't know what that was. And so we had to share that with them. And we also were able to call out what are some of the things that are going to land you in that those top reddish lines, and pulled that from information that we had from the Joint Commission newsletters or things that we had from our own gap analysis. One of the things we wanted to be sure on are some things that we knew, come up regularly: the suicide, the restraints, pain assessment and reassessment. We know they're going to ask those questions and cover that. And we always landed with a leader takeaway and tips. Again, I think you always have to connect the information that you're sharing and make sure people are responding to it in a very active way, that they're not passively sitting back and just taking in that information, that you want them to do something with it. So we really did ask them to do very specific things with the information that we shared. Next slide. Again, just a couple more examples. I mentioned the new leaders. We did some scenarios that you can see here on the left-hand side about, okay, you get the notification that the Joint Commission has come. What are you going to do with that? Or a surveyor comes onto your unit. Now what do you do? We really wanted them to be very practiced and knowledgeable. Also that they had their talking points, and that the staff also had talking points, and that they were able to use the tools that we have provided for them, dashboards that showed the effectiveness of their audits, EPIC dashboards that they could access to look for compliance with clinical documentation. And then again, keep bringing that stuff to the huddles, to your staff, use as you do your rounding, and so on and so forth. Next slide, please. So let's move to what happened during the survey. Can we go to the next slide? As many of you probably know, that first morning is always very stressful and very hectic, and there's a lot to do all at once. We put a little bit of a timeline up here. They had changed the process for how they were going to notify you. You weren't getting that notification at 7:30 anymore, which we missed, but they came right about when they said they were going to come at 7:45. We did issue alerts and posted the banners, as I think many hospitals do, on our internet page. And we sent around a rounding tool for clinical leaders. They already had it, but we pushed it to them just so they wouldn't have to go looking for it. We also activated the command center and started with that brief safety briefing, which went very, very quickly. And we ended up just essentially giving the surveyors one of these badge buddies that has all the code information on it. And that pretty much satisfied them. The whole thing was very super quick. Next slide. So our command center. We obviously, like, a really, really important part of the whole survey process. I'll start with just our escort team. We had 6 surveyors. The preceptor was often paired with another surveyor. So we had 6 survey teams that we had to put together. And we had 3 people per surveyor. Might sound like a lot, but it's done very purposefully. We had our service line director serve as the escort team leader. And that's because we wanted our clinical managers to be on the floors and engaged with their staff, delivering the patient care. We also had our clinical educators serve as our scribes, so they were taking the bulk of the notes. And then we had our an informaticist attached to each escort team. And we, again, with new staff, not everyone is as proficient with Epic as we would like them to be. And so we thought the informatics would be very, very helpful. And they do indeed help. For the staff that stay in the command center, we really used our quality staff, but we also pulled in other areas to support in the debriefing process. We used our risk managers, we used our patient experience manager, patient flow manager. This is really, you know, an all hands on deck kind of event. And so in addition to doing document sourcing, they're also debriefing and pulling the information so that we can begin to act on those kind of findings that happen. If you go to the next slide, you can see here some of the forms that we use for our escorts. The leader had a very basic form that really, it's a short form, really just captured any immediate requests that we have to get and any immediate problems. It was a scribe that took more specific notes and also had a little checkoff space at the bottom to just, we know they're going to cover these things and just check out which things they covered. We really wanted the forms to be very specific to what we needed to provide to the surveyor. Next slide. The next slide is really just a screenshot of the logs that we used in our command center. You can see in the bottom rectangle highlighted in red, these are the different spreadsheets that we had associated with this log. You can see them here. What kind of documents are they requesting to look at? What are the issues that are coming up that we have to start working on? Who are the personnel that they spoke to? Let's pull their training files and HR files and get that prepped and ready to go. And then any patient records that they looked at, so we can see what they had already been through and what they still had yet to go through. Next slide. So one of the last activities is the leadership session, and I put the questions on here that they asked. The top 3 questions went to our chair of the board, and really wanted to know, go back. Really wanted to know what, how board members were brought on. The other topics that you can see in the middle really relate to questions that they told us ahead of time. We'll be asking about and be prepared to speak to those. One specifically about finances. We are 70 to 72% public payer, so finances are always tight, and they wanted to know how we manage that. And then this final question here came from the lead surveyor. You go to the next slide. So this was what our safer matrix ended up looking like. As I had hoped, we had most of our findings in that lower left-hand corner of the box. And then these are the higher risk findings that you can see here. We did see infection control trigger. Robert had talked about the changes to the infection control space. And so that was something that really came through. A lot of the things that he mentioned came through. In terms of keys to success, you're going to see them here. It was for us all about the preparation. We spent a lot of time doing that, and it really paid off for us. Starting strong, being ready that first morning was really, really important. I had been going in early Mondays and Tuesdays because we had a 4-day survey for weeks and weeks, just to be sure I was there. And then we had ongoing communication with the surveyor, which was really, really important. They were great. They were very open. We took a lot of advantage of the time at the end of the day to meet with them, to put subject matter experts in front of them, and just making it as easy as possible for surveyors to do their job. If they can have an easy survey, they're my customer, and I've met the patient experience goals or the surveyor experience goals I have for them. And then just take your time. It's exhausting, right? And you just need to breathe throughout it. And I'll just close with my last slide because I've gone over, I can see that. The last slide is really just a note that was left by our surveyor team for us. This was probably my favorite part of the survey, to get this nice slide from them. It was kind of a surprise, and to hear all the wonderful compliments. We sent these out throughout the week, and it really buoyed up everyone's spirits and kept our energies up. So thank you.
Thank you so much, Erin. I don't see any questions in the chat right now. So I'm going to take that to mean that you were very clear on all of your everything that you presented. So now we're going to turn over to Haywood Healthcare, Laura Sims and Jody Langlois.
Hi, good afternoon, everybody. It's hard to follow that act. So we're with Haywood Healthcare, and we're a much smaller organization. And so I wanted really to speak about how we've used kind of internal innovation to make sure we're ready for surveys. So Haywood Healthcare is an independent community health system. We have 2 hospitals within our system. One is a general community hospital licensed for 134 beds. And we have Joint Commission accreditation with our hospital program. We have behavioral health accreditation and also lab accreditation. We also have a critical access hospital, which is our Athol Hospital, which is a 21-bed critical access hospital. And we didn't used to have Joint Commission accreditation for our laboratory. We used to be accredited by COLA, and they essentially went away in 2024. So we did transition to the Joint Commission accreditation program for our lab at Athol Hospital last year. Next slide, please. And so I'm an old-time quality person. And when I first went into the world of quality, we did dog and pony shows for the Joint Commission. We had presentations prepared. We had all kinds of things prepared in advance. And that was kind of the flavor of things with the Joint Commission back then. And even as early as during the pandemic, you know, we all would be checking our extranet sites every day when we were in the window of a survey to make sure that, you know, if we got that 7:30 notification, that we had a chance to run around and make sure we were doing rounding and ready for surveyors. But as all of us know, those days are really in the past for us. So we don't have the types of resources that Erin is afforded with Lowell and the Tufts systems. And so if you advance to the next slide, we've had to do a lot of this work internally with a very small team. For those of you that are not aware, Haywood Healthcare was in Chapter 11 bankruptcy last year, and we emerged as an independent health system after a year of being in bankruptcy. So in our organization, we don't have a lot of luxuries of spending money to utilize consultants or other external folks to help ready us for survey. And so this is really the approach that we took to make sure we were ready and able to successfully complete our survey as a very small organization. And in our areas, our leaders and staff, we don't really have just one hat in our organization. We wear many, many hats. And so for us, getting ready is a little bit of a different process. So how we chose to plan to be ready is really by prior planning internally. We make sure that we always have our team and our process available and updated for that safety briefing, because as you can see by the programs that are accredited, we do get a lot of surveys from the Joint Commission in our small system. We take the survey activity guides that the Joint Commission shares with accredited organizations, and we really look at the survey activities because we then internally look within our team to determine who is going to be working with the surveyors and part of the escort team, if you will. Because we don't have lots of resources of additional people to step in. And so we use our many hats in different ways as we plan for the survey. But we do identify people in advance and do some training with folks that are going to need to scribe, because in all likelihood, they haven't scribed with surveyors before. We basically set up a modified small incident command structure. And we don't have lots of people manning our incident command because we're just such a smaller system and have so much more limited resources. So on the next slide, you'll see about 12 months prior to when we anticipate a survey, we really start what we call our chapter champions review. And that's basically looking at each of the chapters in the Joint Commission accreditation standards and assigning folks as groups of people to go through each standard and each element of performance. And then internally, we assess ourselves to make sure that if it's an element of performance that requires documentation, that we've reviewed the policy or documentation, that it's current and it's alignment with the elements of performance. We create basically a master spreadsheet with a tab for each of the chapters at the bottom. And then we use that as a communication vehicle because we basically have recurring meetings with each of the Joint Commission chapter champions to go through each of the standards and elements of performance. We anticipate being surveyed here at the Haywood Hospital campus late this year, and we've already established our chapter champions and have started doing reviews based on the chapters. And some of the chapters is leadership involvement, some we include staff and others, because again, we don't have some of the resources that some of the bigger organizations do in the Commonwealth. We independently and as a group collaborate and determine whether we're in compliance with our standards, and we pay particular attention to make sure that we're in compliance with our policy updates because we don't update policies annually for most things. We have undergone a series of changes like with our policy management software and programs. So we really want to make sure that we're compliant with our policies. And we look at it from every angle that we can because we just don't have some of the fancier tools to help us automate this because of the situation our system is in. During these meetings, we assign responsible parties. If we find that we have gaps or we need to update a policy, we talk about that in our meetings. And then when we meet the next time, we gather and update each other to make sure we're making progress in forward motion in a timely manner so that we will be through all the standards and elements of performance before our surveyors show up. We also created a little bit of a different structure this last survey because we don't have a large incident command structure. Our incident command is generally staffed by one, maybe two people, and that's really to review all of the documents that the surveyors are asking for. And so in these spreadsheets, we have tried and created links to documents and policies. So we're not fumbling around looking for the most current version of something, or wondering where do we find the documentation that corresponds to this element of performance. And we really have found that this system has served our smaller system well. If you'll move forward to the next slide, you'll see really an example of this master spreadsheet. And so we basically outline each of the standards and the elements of performance. And in our chapter champion meetings, we talk about our findings. If something is non-compliant or not, we basically have a color-coded field under the status column where we update this during each of our meetings to make sure we get everything updated and that our documentation is in order, again, because we don't want to be fumbling and floundering on the day of the survey. If you'll move to the next slide, please. And so what we did on our last survey, and this may become a moot point after the information shared by Dr. Mort this morning and the Joint Commission surveyors, we basically really linked a lot of our documents to our spreadsheet because, again, during our last survey, we didn't have a SharePoint site available, and we wanted just to make sure that we weren't fumbling or floundering. So I'll let Jody talk about our world in Google land. We don't use Microsoft Word here, but we use Google. And so we chose to link documents again so that our incident command wouldn't have difficulty finding things that were being requested by the surveyors. So Jody, I'll turn it over to you.
Sure. So I just wanted to add with the chapter champions, I have been both a facilitator and also a participant or a subject matter expert. And I think that it's helpful because, you know, whether you're new to an area or you're not confident in your policies, I know a lot of times we're marking our policies as reviewed every 2 years, but that doesn't mean that we really reviewed them and ensured that we're compliant with the standards. So this is very helpful to have these conversations and connect with your subject matter experts. In terms of the policies, it's nice when we're having these conversations. We are currently using a Google platform for policy management. And so this allows us to create a link which will, we're able to go directly to the policy. So if we update the policy at any time prior to survey, this link is to the updated policy. So that is very helpful. I think that, again, the chapter champions, it lets you know where you are. And this is helpful linking the policies because, again, we are a small organization and there have been times when the surveyor arrives and we don't have our subject matter expert or any of our subject matter experts. So this is certainly an excellent reference for us because we often make notes about conversations that we had when we're reviewing the standards. So we know what policies to reference and we often have just a little bit more information. So if we have to move forward without a subject matter expert, we have that knowledge at our fingertips. If you could go on to the next slide. And this is just an example of, again, we were looking at the transplant tissue policy, and you can see that as you click the link, it opens our actual policy for viewing. On to the next slide. We also used something similar during our last survey at the Athol Hospital with human resources. When we went through our documentation, there's hyperlinks here, which would connect to show folks' license, their education verifications, and so on. And the surveyor really appreciated this was very concise and easy to move through. So as they give you your people, if you do have the ability to link these documents, it does really make it very smooth and fast for the surveyor to go through this information. On to the next slide. Laura, I think you were going to talk about this.
Okay, so yeah, we use a modified incident command structure, and again, it's not staffed with a lot of people because we're a smaller system. So basically, we've identified in advance of the survey who's going to be doing what. And our incident command, it may be one person, depending on who's in the facility and who is not, because we don't have a lot of bench strength with backup, and we never know when the surveyors are going to be here. So these linking of the documents and us having these shared spreadsheets is very, very helpful for a smaller system because your leader may be on vacation when the Joint Commission shows up. And this way, everybody on the team really does know what is the most current document. And we're not, again, fumbling, looking for things or providing old documents, which we have to retract or change at the end of the day or when we have an issue pop up. We basically open a virtual meeting link at the beginning of the survey, and people and leadership are able to hop on and off of that link. So as we get requests from scribes for what surveyors will want to do or where they will be going next, it allows our incident command folks to communicate with other areas of the organization. And we keep that meeting up basically for our entire survey. It has been very helpful for us to capture all of the requests and documents because like many other hospitals, we really try to memorialize the documents that we look at and the things that the surveyors evaluate when we do our after action reports and our end of day summaries to inform our leadership team and board of our how our survey is progressing. On the next slide, you'll find at the end of the day, we basically send a wrap up of each day. And so we collaborate after the surveyors leave and make sure we've identified everything that was requested and all the areas that were visited. We then send out an all management email to everyone identifying the good things that happened the day, the issues that were addressed, and any nonconformities or deficiencies that we saw in one area so that we can pay particular attention in the next area or on the next day to make sure that's not going to be a repeat finding. So that will become pattern or widespread deficiency on our survey report. We make it a point to give our staff kudos for effective and positive interactions with our surveyors because like your organizations, our staff are new. Some of them have never interacted with surveyors and it's kind of a frightening thing when you're a staff member the first time you're asked about, how often or how quickly do I need to report critical values to the physician and what is my policy on that? The staff can freeze up. So I think the survey team that goes around with the staff does a lot of nonverbal communication with the staff to help encourage them. And we give them, attaboys as we're leaving the units, but then we make sure we definitely acknowledge the staff because it is very stressful for them. And many times they're really not totally sure on how to answer things. And they just need that acknowledgement to really feel good and know they made a positive impression or did a good thing during the course of the survey. And they were able to basically explain how they enhance the care of our patients. We share the plan for the next day's activities or the next areas that the surveyors will be going to. And this gives leaders a chance to make sure they pre-plan for the following day, again, so that we don't have repeat deficiencies or questions in advance so that the following day runs smoothly. And it really does help us to correct gaps and keep them at a low, limited level and not going into more of the pattern, bigger, widespread pattern deficiencies that, of course, require additional corrective actions when you receive your survey report. And on the next slide, Jody will tell you how we share communications internally as well with our survey progress and the things that go well.
Sure. So over the years, I have heard the colors of the matrix referred to as mustards, ketchup, and barbecue sauce. And those are the areas that are likely to harm a patient or visitor or staff. And so we decided that we would create a matrix and we would bring the relish. So this is likelihood to help a patient, visitor, or staff. And we basically documented all of the positives that were said throughout the survey, again, to give those accolades to the team, to really highlight that with leadership as well. It's just as important to learn from the good that you do. And it is a very stressful time for all, being under the microscope. So while we're looking, it's excellent to be able to give that positive feedback and bring the relish.
And then just to wrap up on the last slide, it can be challenging in a smaller system without a lot of additional resources to prepare for a survey when you may be the leader, the subject matter expert, and having to accompany a surveyor. But this process really has served us very well in a system with very limited resources. We've been able to successfully apply these same principles to unannounced complaint surveys because I'm sure your organizations are much like ours. We have seen an increase in unannounced complaint surveys based on some of the changes that CMS has indicated that the Joint Commission has had to make. But we truly do look very much forward to the new enhanced SAFER matrix with the better understanding of the findings, because we all had trouble decoding them previously. And it'll be very interesting to see how to use the SharePoint portal on the Joint Commission extranet site, and how that will evolve over time, and also the benchmark information, because all of us always have that question is, how did we do against others like us? And that's always been a bit of a question mark for us. So thank you for listening. This is how we do things in a very small system, and I hope this has been helpful. Thank you.
Laura and Jody, thank you so much for sharing your recent survey experiences. I'm sure a lot of people learned a lot. Very informative and insightful, and certainly can appreciate the challenges being a small system, small hospitals. So thank you. If anyone has any questions, I don't see any in the chat right now. So we can
Kim?
move on. Oh, yes, go ahead.
Hey, I just want to congratulate you for the relish concept. And I also just want to share a sneak preview of coming attractions. We also at the Joint Commission Central Office appreciate that there is so much opportunity to give you positive feedback, and that's done verbally. But we also appreciate that having it done in a report format would allow you to have a more balanced report and to provide more balanced feedback to your leadership. So bravo on the relish. I hope you know that I hope it's okay, Jody and Laura, that I shared that back at the central office.
It's not copyrighted. Yes, you can.
What I just want to share with the team that's working on this project, it's one of the ones I'm working on, is that, look, people want this. It's great. And, you know, we also used to call it barbecue sauce at Mass General, but we didn't have the relish component. So bravo, and really nicely done. Congratulations.
Thank you so much.
Thank you, Dr. Mort. Okay, so now we can turn it over to our final presenters of the day from Boston Medical Center, Jody Larson and Sandra Montron. Take it away.
Hi there, everyone. I'm going to start for the Boston Medical Center presentation. Jody Larson here, Chief Quality Officer, oversee quality and safety. And I think what's interesting is you think about the different presentations you've heard, and I've had experience in smaller hospitals, bigger hospitals, a 14-bed hospital down in Nantucket, that Joint Commission requirements are the same, and the work that has to go on behind the scenes is the same. And so it's impressive that we all have similar ways that we sort of tackle these, because we have to sort of meet all the CMS COPs, no matter the size of the hospital. If you go to the next slide, I'm going to share a little bit of background about BMC, and then Sandra's going to get to sort of the meat of how our survey, most recent survey went, and give you some of our experiences there with it. BMC is a private hospital, public mission. It was formed by the merger of two different hospitals in 1996, Boston City Hospital, and then Boston University Hospital. It's really continued to maintain both the public mission as well as our academic mission. And we like to think of ourselves as a centerpiece of the city's public health network. And you'll see over there on the right are some real pillars that are important to our mission, including respect, moving mountains, and greatness. Next slide. A little bit of background on BMC is we serve patients who are disproportionately minority and low income. About 70% of our patients identify as people of color. Greater than 50% have an annual household income below the poverty line. And about 30% of our patients use a primary language other than English, which certainly makes providing care it's challenging as it is, it's more challenging with some of these disproportionate patient population that we see. And over there on the right, you'll see that is a comparison to some of our other AMCs in town. The low income patient population is a little bit less, about 15%. Next slide. And we continue to grow, like everyone else has shared with some of their background, that we have increased our total beds to about 600 beds. And that has increased in my few years here at Boston Medical Center. We are we continue to have a really high occupancy rate. I'm surprised it's not more like 95%, but it's 89% as we list here. Admissions close to 25,000, and you'll see down in the middle that our emergency department visits are about 140,000. And we have a very a young actually nurse force. That's one of the challenges you think about preparing for the Joint Commission is you've got new and inexperienced staff. And certainly the training has been different for a lot of these, their physicians and nursing staff over these years. So that's part of the challenge as you think about preparing for the Joint Commission. And I'm going to turn it over to Sandra here, but what I will say is that it's interesting that we all have had similar experiences, but I think that it is this background and all the work that you do every day that really gets you ready. As Sandra tells you about our visit and that how we were prepared or not prepared for it. Go ahead, Sandra.
Thank you. Thank you again for having me here. Can I have the next slide, please? So I'll start off by a little bit of overview. Jody gave the hospital background, but I think what many don't realize is how many sites that we have oversight. We have over 30 locations that accreditation is over as well. And as most of you have shared and know, the resources and the staff are limited, but we're still able to do it. So in the next slide, I'll give you a little bit of our background or our keys to success, which is ongoing. I tell everyone, we're open for business, so our readiness is on day in and day out. As long as our doors are open and we see in patients, then we're doing this every day, not just in the window that we get prepared. So I'll go through a little bit of these as we go through. So next slide. One of the things that I'll share with you, which is actually my favorite part of my job, and if this ever gets taken away, I'm not sure if I can do it, which is compliance rounds. It's actually going out into the units, and with these compliance rounds, we separate them. In the inpatient units, we do them on a monthly basis unannounced, and then we have quarterly rounds that we do with the team that we bring, facilities, infection control, and other team members. And then we have the ambulatories that we do the same thing, and then we have the community health centers. But part of these rounds is using the tool that I refer to as an open for business, which is basically a checklist that we all should know what to go and look for, the first sweep that we do into the unit. And the analogy that I tell everyone is, Joint Commission is an open book test. We know what they come in for, and no one ever fails a test when you study. It becomes easy. So that's my motto when I am there in the unit doing rounds and looking for the facilities and asking questions to the staff and making sure that they feel comfortable. With the turnaround, as all of us have experienced, having people feeling comfortable with having a staff member coming to them and asking questions is the readiness and how I say we study for the test. So next slide. With that, as I shared with you, as we go out there, we're doing traces in real time and giving feedback in real time to the staff. We're taking the opportunity to teach about what surveyors are going to look. And, I go around and out of nowhere, I'll just bump into anyone and they'll know that I'll say, what's the contact time? And, getting people comfortable or the staff comfortable with answering that, getting staff comfortable that when we go out there, we say, hey, do you have a second? Can you tell me about your patient? Can we do a little chart tracer and look in, for your pain assessment and reassessment? Having meetings with the leaders and ongoing topics of notifying them what are the new standards standards? What's the gap analysis that we have done? We also have found this past year, one of the things that was very helpful was the new manager survey readiness meeting. So every month we decided to have a Zoom meeting, and it basically spoke to all managers that you're new to this role in leadership, come and let's have our 101 readiness. That talks about, what is it that the surveyors are looking for? How'd you get your unit ready? How'd you get your staff ready? The ongoing sustainment. And then we decided to stop having the group meeting for, I call it readiness, no longer joint commission, but just survey readiness. And we decided to just divide it to have the inpatient leadership attend those meetings. And then we did the same thing for the ambulatory and then to the CHCs. Although some of the information overlapped, but it gave the opportunity to give focus points specifically for them, for their areas to be able to take it back to their staff and continue the readiness. And then the other piece that we've gotten great feedback is our survey readiness newsletters. And with this new newsletters, we have the overall dashboard, which shows the findings that we had during the rounds. So transparency throughout the organization is broken down by ACO, ACNOs, and then it's broken down by the units. And under specific units, it'll tell you exactly what the findings were. So no mystery of who got what. And given the opportunity. And then we also have that report that comes out on a quarterly basis. So overseeing the compliance overall. And then we decided that there's not enough of us to go around. So for the ambulatory unit, we added secret choppers, which are local leaders in our own departments that get assigned different units, and they sustain the compliance rounds as well. Next slide, please. So here we were. I thought, we're on point, just like, we're getting ready. We know that we have 6 months out or 4 or 5 months to go. We've ordered our signage, like everyone else. We have our new national patient safety goals. We have new oxygen signs. We have the lanyards ready to go. Meetings have been set just to, hey, okay, let's review again. What's the escorts are going to do, what the scribes are going to do. It was all ready to go. We had until April. My prediction, which I had a very good track record of predicting when Joint Commission was going to come. I was expecting them probably late February, March. We were on point. So next slide, please. Yeah, things changed a little bit. So next slide. On December 3rd, I just finished doing rounds. And I'm coming back up to my office at 7 o'clock and my phone rings and says, hey, Sandra, we have surveyors here. Okay, we have surveyors, nothing unusual. DPH is around. Okay, no problem. I called Jody and I said, hey, Jody, we have guests in the lobby. So I'm not sure what they're here for, but I'm in the elevator. And Jody said, well, I'm in the lobby. Let me pick them up and we'll meet upstairs. I said, okay. I came into my office to send out the message that we had surveyors and received at the same time the notification from Joint Commission. So not only were they early over 4 months, totally earlier, the usually time at 7:30, they showed up closer to the 7 o'clock mark. So 2 surprises. And I'll share with you that the part that also made it interesting is that my second hand in command was also not here. So I was just like, oh, wait, my team really is not here. But I was happy to say that, we had for the first time, we had our 4-day survey. Historically, we were 5 days, and our number of surveyors doubled. So we had 15 surveyors arrive all at the same time. So reached out to the command center, got the communication sent, FGH. The beauty about it is that the binders for me, yes, I am old school. I have binders still. We always keep those binders ready, including the survey documents that they request. We have all of those ready. It was just a matter that I hadn't put it all into the bin to get it transported to FGH. So we got everything ready, transported over to FGH. And overall, as you saw some of the feedback that we had, they were very impressed with the care that we provided and the unexpected. And I had the fun of showing and telling them, listen, I'm all for early Christmas present, but I needed 1 more week to get my shiny new signage out for the staff. Next slide. So with this, I wanted to share a little bit more this survey, this presentation, to give you a little bit of an overview. Nothing unusual. As I said, the we never, can fail for a test when you study for it. When you look at these findings, they're not any different than what was shared to us at the beginning of the presentation. I think for me, the one that was surprising, but we laugh about it, and I see and I've heard that other folks have had it, was the following the IFUs for the glucometer. Who knew that the IFUs were specifically about the blessing, 3 times up and 3 times vertical? So if you haven't, this was a simple reminder to me of not taking any IFUs for granted. Review your IFUs and making sure you're following it to the T. There is no deviating for it. It's a 2-step process, and they will continue to ask. So we had one conditional finding that resulted in a 45-day visit. And again, the infection control findings, the comments that we see throughout, and you see the other findings that we had. Most of our findings, I gotta say that it was the first 2 hours. Once I told everybody, reminded everyone, pull up your Open for Business tool. Most of our findings decreased very quickly. I think I also enjoy the fact that for the first time, what I said with the 14 surveyors, I only had 1 nurse in the team. The whole team was physicians. So it was very interesting to have a team composed of all physicians, and they left no place unturned. They had the ability to go to many more places. So we know the inpatient world, they always hit every single unit. Next slide, please. But the ambulatory was also one that we had more than enough time for them to go through. So that was really fun to learn. The other piece that I found, for the first time, they implemented the culture of safety. They asked to interview staff and patients alone. And I asked, so what are we looking for? And they basically questions about culture of safety. The HR tracer patient identifying for us was a little bit different. With the arrival, they asked if I could provide them a list of all of our staff, meaning nurses, social workers, EVS, and so forth. And they selected different staff members accordingly through there, just randomly. So it wasn't by speaking to staff that they selected the staff. And then the other piece that was new for us was that we had one surveyor who flew in for 1 day to do closed chart reviews, which that was a little bit more like the CMS when they come in and they do some closed chart reviews. Next slide, please. So overall, I think that what I refer to our recipe works, which is the continuous compliance, being out there, communicating with the staff, having that report and that relationship, and reminding them that, we're open all the time, not just when, our 18 windows. And I share with the staff that, Joint Commission is a little bit more predictable about when they're coming. It's our friends down the street, DPH, they're local, and we never know when they're going to come, and we have to stay ready. So the relationship of feeling staff comfortable, that I say it's joint for a reason, we're all in this together. So cannot be everywhere all the time. So building that report that they'll feel comfortable and say, hey, Sandra, we're coming across this. Can you give us your feedback? Or we're thinking of starting this. Are you okay with that? And that's really, to me, I think the biggest success, that people feel comfortable in asking before implementing or putting anything. And the teaching, having staff feeling the confidence. And that's the part that clearly comes through in every single survey. And I share with the team that I think for this role, I'm less than 5 feet tall, so I can become 10 feet tall with all the great appraisals and recognition that gets done for the survey. But for me, one more click, please. For me, what's important is to have fun. As long as people are having fun, then you're able to sustain things a little bit in the understanding and the readiness mode. Next slide, please. So overall, that's our survey overview of Joint Commission. One more click, please. So you got this.
Sandra, can I add something to?
Please.
Yeah, as I said, I think that, we were definitely surprised. Sandra and I, she's not joking when she talks about, she and I had met on a Monday to talk about preparing, and again, these meetings coming up with the VPs and leaders and rounds and what we were going to do and sort of the booklet and all these things. That was a Monday, and then Tuesday morning is when our surveyors showed up. So we were definitely very surprised and really like, what, the whole team? But to that point, I think we were grateful that all this work had already been done, that I don't think we would have done any better. And our survey, if they had come when we had thought they might come. Really, I mean, Sandra, would you say that too? I don't think we would have done any bit better. That we were ready every day, and so it was kind of just a relief to have it done, because we would have put so much emphasis and time and energy on it. that we would have probably had the same findings that we had. So I think we were just excited that all this background work had been going on, and just the regulatory readiness every day really proved its point that we were very happy with our survey.
Agreed.
Very happy, Sandra.
It was a nice Christmas gift.
Okay, well, who doesn't love to end with a cute puppy? Thank you so much. Looks like we've got a couple of questions or comments, although they may have already been addressed. How often do you round each unit per year? And it looks like maybe Angela from your team responded to that.
Mhm.
I don't know if there's anything additional that you want to add to that.
No, that's as I said, the rounds are unannounced and announced. The quarterly rounds are announced, and then the monthly are not. And as I shared, we're open for business. So whenever we're coming around, you should be ready to have the unit ready for us to round and report that. And then I see the question also about the 5 days. Yes, we were notified about the 5 days after we had completed our 18-month application, and they let you know about the number of surveyors and the day of survey. So they did give us that notification.
Excellent. And then some kind words from Xenia. Sandra and team did a fantastic job with our preparedness. Command center activation was seamless, and we leveraged Microsoft Teams to coordinate and execute all information sharing. Our surveyors got what they needed when they needed it. It's very good. All right. Well, okay. It looks like we have wrapped up a little bit early, which is great. I'm sure everybody could use a little bit of extra time in their day, go get some coffee, take a walk, or just get ready for your next call. Thank you to all of our speakers and panelists today. We really appreciate you joining us and sharing your experiences and your time, which we know is so valuable. And thank you again to our sponsors and strategic partners for underwriting today's event. We hope to see you all at future events. It looks like Dr. Mort, you have something else?
I do. I just wanted to thank all the presenters who shared their time, took the time to share their experiences today. Really impressive. And wanted to congratulate all of you. And Kim, I did get some information about these document uploads. I put it in the direct chat to you. So
Okay.
perhaps if you could flip that response to the general chat, the person who was looking may still be in the audience. But my main point of jumping in here is just really to say, I started by saying I'm so proud to be from Massachusetts. And I think at the end of this, I'm even more proud. So bravo, everybody. And thanks to MHA for sponsoring this really exciting event.
Thank you so much, Dr. Mort. We really appreciate you having you here, representing both Massachusetts and the Joint Commission. It's really a wonderful full circle to have you be part of this program. Thank you, everyone. As a reminder, we will be sending out slides and a survey after this event. So keep an eye on your inboxes for that. And if there's any follow-up questions, you know how to reach out to us. Thank you all. Take care.